Good morning, everyone, and welcome to the House Committee on Health and Human Services and Elderly Affairs. We have several Senate bills we will be engaging in public hearing with today. But before that, I'd like to ask you to please join me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you, everyone. And again, welcome. Yes. Audie? No. Okay, the first bill for our consideration this morning is Senate Bill 32. I want to keep saying House bills, but it's Senate bills 32. And I'd like to recognize the prime sponsor, Senator Rosenwald. Good morning.
Thank you. Thank you very much, Mr. Chairman. It's a pleasure to be here. For the record, I'm Cindy Rosenwald, and I represent Senate District 13 in Nashua. And as chair of the Opioid Abatement Advisory Commission, I'm pleased to introduce Senate Bill 32. This bill makes changes to the operation of the Opioid Abatement Fund, originally created in 2020 to manage the distribution of settlement funds for opioid litigation that will be coming into the state for the next 18 years or so. In total, we expect over that period, New Hampshire will receive more than $300 million to mitigate the harms of the opioid epidemic. So when we receive a check, 15% of that money goes out immediately to the 23 litigating subdivisions, and the balance goes into the Opioid Abatement Fund. The Opioid Abatement Advisory Commission has the responsibility and authority to grant these monies for a variety of purposes laid out in statute. There are 22 members on the commission representing subject matter experts, HHS, Corrections, Department of Justice, the Governor's Commission on Alcohol and Other Drugs, and county and municipal governments. We held our first round of grant applications last fall for $6.6 million. The contracts for award grantees are being finalized to go before the Executive Council, hopefully next month. Since that first round, more money has come into the fund, and we have just agreed to issue an RFP and make $5 million for reimbursement of medications for substance use disorder available. This bill comes out of our experience in soliciting and awarding grants over the past year, and it does several things. First, it establishes a requirement that we give out grants at least once a year when there is at least $5 million in the fund. We will collaborate with HHS on the number of times we will do this in any given year. And I should also note that there's really likely to be at least $5 million in the fund every year for the next 18 years because of the way the settlements are structured. But however, there is currently no statutory language about how often we give out grants or how much money we would need to give out. Second, it clarifies and makes a couple of additions to eligibility categories for grants. These are recommendations from the subject matter experts. It also expands the reimbursement for medications for substance use disorder treatments to recognize that naloxone is not the only FDA-approved product. And finally, it updates language to reflect best practices in the field and fixes a couple of typos in the statute. I'd be happy to answer questions, but both the DOJ is here and HHS is here, and they probably are better subject matter experts than I am.
Okay, do you want, you're willing to answer questions?
Yes, I am.
Sure. Are there any questions from committee members? Representative Weber.
Thank you, Mr. Chairman, and you may choose to defer this if you prefer. I was just wondering about the 15% that we're not talking about, and you said that goes to litigating subdivisions, and I just wondered, as a matter of curiosity, who those were.
Mr. Buffetti from the DOJ can reel them off by
Okay.
memory, but
I'll wait with bated
it's a
breath.
range of, I know Nash was one, I think Laconia, maybe some counties, he knows.
Keating is one.
Thank you. Anyone else? Any other questions from committee members? I'm seeing none. Okay,
Thank you.
Thank you, Senator. Okay, also signed up to speak is James Buffetti from the Department of Justice.
Good morning, Mr. Chairman, members of the committee. My name is James Buffetti. I am the Deputy Attorney General, and I have been the point person at DOJ for its opioid litigation since 2015. I'm also a member of the Opioid Abatement Commission that Senator Rosenwald just mentioned. So we come in support of this legislation. These are recommendations made by the commission that would clarify and streamline some of the processes. The object being trying to get this money out as quickly as we can as it comes in so that we can use it in our communities to help abate the opioid crisis. I'm happy to answer any questions about the settlements, the various settlements, the amounts that are coming in. There was a question from Representative Weber about which communities are receiving the 15%. And I can say that those communities are the ones that filed their own lawsuits, and they include all 10 counties, plus Berlin, Claremont, Concord, Derry, Dover, Franklin, Keene, Laconia, Londonderry, Manchester, Nashua, and Rochester. And I can tell you that with the money that's already come in, that $6.68 million has already been distributed to those 23 subdivisions under New Hampshire, the New Hampshire statute. We anticipate, I think currently we have in the opioid trust fund, we have approximately $38 million. Most of that money came from a one-time settlement that the Attorney General reached with Johnson & Johnson to settle our opioid lawsuit with them. We went on our own. We didn't join the national settlement. And New Hampshire received a one-time payment of $31 million last fall from J&J to settle their opioid claims in New Hampshire. So all of that money is in there. But as Senator Rosenwald said, these are structured settlements. They're all individual settlements with all individual terms. Some are a result of bankruptcy proceedings that are yet to be resolved. Some have been resolved. And that there will be periodic payments coming in over the next 17 to 18 years. My estimate is that at the end of the day, that New Hampshire will receive about $310 million over 18 years. So this commission will be functioning for a long time and will be trying to figure out the best, most effective ways of using the money to help address the opioid crisis. By law and by bankruptcy settlement, all of the monies have to be used for opioid abatement purposes. Things like treatment, transportation to treatment, housing for people coming out of treatment, drug court, for naloxone, for medication-assisted treatment, which is the most effective way of treating people with an opioid addiction. So I'm happy to answer any questions that you have about the settlements and any other questions that you may have for me.
Thank you. Questions, Representative Merchant.
Thank you, Mr. Chair. Thank you for taking my question. In regards to the funds being used for treatment abatement, if you will, is there any focus on trying to build programs to prevent the use of opiates in the first place?
Yes. Well, there is, so as the senator said, the statute contains 15 or so permitted uses of the opioid money. So the grant applications have to conform with one or more of those uses. There is an approved use for prevention work, especially in schools, and so that would now be dependent upon schools and other organizations who would make proposals to do exactly that. And if they did, then that would be considered by the commission. We make recommendations to the governor and executive council for the actual funding decisions.
Follow-up.
Follow-up.
Is the restriction limited to schools, or could it be used for something to do with adults? Because part of where I'm going with this is we have a House Bill 66, and part of it is trying to find ways to design, if you would, the ability to use non-pharmacological therapies in order to not utilize as much opiates to begin with. And part of that is trying to figure out how we can fund that kind of initiative, because if we can keep people from using opiates in the first place, we minimize the issue we're dealing with today.
I think that there could clearly be a way, if an organization, a nonprofit, or a state agency, or a local government had a proposal, I think that they could certainly fit it into the approved uses that are in the statute.
Thank you.
Other questions? Seeing no other questions, thank you.
Thank you, Mr. Chairman.
Also signed up to speak is Jake Berry from New Futures.
Good morning, Mr. Chair, honorable members of the committee. My name is Jake Berry. I'm the Vice President of Policy at New Futures. As many of you know, New Futures is a nonpartisan, nonprofit health policy and advocacy organization. We've been working for nearly 25 years to address alcohol and substance use issues in our state. I don't want to repeat too much of what's been said this morning, but I do want to emphasize New Future's strong support for this bill. Specifically, we support the provisions that clarify that the Opioid Abatement Trust Fund can be used to support harm reduction programs, as well as the language that requires the Trust Fund's Advisory Commission to work in coordination with the Governor's Commission on Alcohol and Other Drugs and other relevant state plans. First and foremost, harm reduction, as I'm sure you all know, is an approach that emphasizes engaging directly with people who use drugs to prevent overdose and connect individuals to treatment. It's increasingly recognized as a critical part of the continuum of substance use disorder services. This proposal to add harm reduction referenced in the bill as primary, secondary, and tertiary prevention and program services is a natural extension of the work of the Trust Fund and would build on the legislature's work from last year, adding prevention programming in SB 275. Incorporating the harm reduction would close the loop and would ensure the full continuum of SUD services can be funded through the Trust Fund. In addition, we believe that empowering the fund to work in coordination with the Governor's Commission and in alignment with other state plans will enhance the coordination of these bodies and ensure a comprehensive funding plan for substance misuse programs throughout our state. With that, we ask you to support this bill, and I'm happy to take questions.
Thank you. Questions from committee members? Representative Palazzo.
Thank you, Mr. Chairman, and thank you for taking my question. In your experience, what's the different success rate for these programs for people for substance abuse disorder, especially in relation to opioid?
Specifically around harm reduction programs?
No, like if somebody has substance use disorder with opioids, like what's the success rate if that person participates in one of those programs, how many of them stop abusing opioids?
Sure. I can tell you, so I don't have the data in front of me, but there are many different parts of the continuum of services for substance use tradition. Each one of them comes with different data and different success rates, as you say. Certainly we see harm reduction as addressed in the provisions of this bill as, a really important piece to connect with people who aren't ready to fully enter the treatment system yet, right? People who, for whatever reason, are still determined or still experiencing substance use disorder and still in active use of substances. Providing them with with clean needles, clean equipment really prevents fatal overdoses. It prevents deaths. It also is an incredible opportunity to connect people with information about treatment programs for when they are ready to enter treatment protocols. So, I can get you more hardened data, but it is, here in New Hampshire and all across the country, these kind of harm reduction programs are just seen as a critical entryway to getting people into the substance use treatment continuum. Sure.
Thank you. Other questions? Representative Merchant.
Thank you, Mr. Chair, and thank you for taking the question, Mr. Berry. On the back of your letter that you handed out, there's a diagram. Is that coming from where? What's the reference?
I do apologize. I'm here on behalf of a colleague who drafted that testimony. So I don't know. I'm happy to follow up on that and get you the source for it.
Thank you.
Sure.
Other questions? Seeing no other questions. Okay, thank you.
Thank you all.
Also signed up to speak is Jenny O'Higgins from the Department of Health and Human Services. Good morning.
Good morning. Thank you so much for having me. I'm Jenny O'Higgins. I'm the legislative liaison for behavioral health for DHHS. So the department has worked closely with the commission on all of this work and is in support of all of the language changes. Really wanted to just be here today because we did submit a fiscal note on this bill, but because the actual language changes throughout the bill are not what makes the need for positions in the department, that language was removed in the fiscal note. So I just wanted to make sure to talk a little bit about the capacity for the department to make sure to move the opioid abatement funds quickly and monitor and oversee them really well. And so that's one piece that we just wanted to make sure to talk about today. So all of the language pieces everyone else has already spoken to, they are best practice and progressive and help us to destigmatize these issues. They also make sure that we're serving people appropriately with evidence-based practices. So in full support of all of the language changes. We also worked closely around making sure to collaborate with the department so that we can get those solicitations out. So really what we had put in our initial fiscal note was around having 3 positions, one that is currently funded with these opioid abatement funds today. That was approved by the commission August 1st, 2022. But we are looking to codify that position so that they can continue to monitor all of these solicitations, get the procurements out in a timely manner, and get them to contract. And additionally, we were looking to have a part-time auditor and an accountant to specifically work on this fund. And those positions are all mirrored after other programs that we have of a similar size. So based on the amount of funding and how we move that funding through the department.
Thank you.
Thank you.
Taking questions or
Yes, of course.
any question? Representative Shapiro.
Thank you, Mr. Chairman, and thanks for taking this question. This may be tangential to this bill, but having, hearing about the FDA approval for Nexalone over the counter, and seeing that this bill talks about opioid reversal agents and the reimbursement for them, is it within your purview to know how those will interact with each other? Will the state be reimbursing less people? Will more people be having to be paid for these medications over the counter?
So at this time, the over-the-counter approval has happened, but it has not had implementation. So we don't know all of the details of how that will roll out. At this point, I see it as additional potential access. But if people don't have health insurance coverage and go to get that over-the-counter, they may or go to pay for these things, they may not be able to afford them. So making sure that we continue to have any opioid reversal agents available through statewide funding. At this point, our federal grants still support the purchase and distribution of naloxone, and we would continue to do that from the state perspective. And the over-the-counter would just add an additional access for potentially for people.
Thank you.
Sure.
Representative Weber.
Thank you, Mr. Chairman, and thank you for taking my question. I want to back up a little bit because you were talking about the fiscal note, and I'm apologizing because I've lost all control over my email. Have we had the fiscal note, or did you say you'd withdrawn the fiscal note, or I didn't quite understand. It sounds to me like you've got one funded position that you are confirming in this legislation, and then you're asking for the auditor and part-time.
Yes, thank you for.
And could you just point me to where that is and point me to whether you have a fiscal note or have sent the fiscal note or are doing, what's happening with the fiscal note?
Thank you. I need to just take a breath and slow down, I think, too, because I'm coming in a few minutes late from something else. So need to wrap my brain around this and better explain myself. So thank you for helping me clarify that. So we submitted a fiscal note worksheet as the department. The legislative budget assistant said that the positions are not due to the changes made in this legislation. And so the positions actually would have been needed in the legislation when it passed in 2020. However, we hadn't received in money at that time when we passed this initial piece, and we were working to build up the commission to get to a place where it was ready to do a procurement. Now that we're starting to move funding, and we're realizing the amount of funding that will flow through the department, we want to make sure we can move that at a steady pace, that we can put these procurements out quickly, that we can get the contracts into place, and that we can monitor and oversee the contracts in an efficient way. And so for those reasons, we've recognized the need for the positions. The commission also recognized that need for a position, and at this time has funded one project manager for abatement. And additionally, we're looking to add an auditor and finance person to continue to move the contracts. And we based those positions on other similar sized grants like state opioid response and our block grants.
Well, sure, follow up.
Okay, so I got that last bit the first time around. So am I correct that what you're saying is we're just not thinking about those positions in the context of this legislation? This legislation is what it is, and you will seek those positions elsewhere?
So I think we have several potential ways forward. One is that the commission has already funded one of the positions.
Right,
So we
I
could go
understand.
to the commission and ask for the funding for the 3 positions in that way. It could be potentially codified, the position could be codified in this piece of legislation or through HB2. So I think those are sort of 3 pathways.
So all I'm really trying to nail down is whether there is or is not a fiscal note, whether there is going to be or is not going to be a fiscal note. And maybe the question is for Mr. Chairman, whether this is going to finance after it finishes with us.
I don't believe this is an early bill.
Okay.
I don't believe it is.
Okay, well, and if the fiscal note is being divided off from this, it wouldn't be. So I think I've clarified the situation enough for my purposes, given that we're the policy committee anyway. Thank you, Mr. Chairman.
Thank you.
Thank you for taking.
Thank you.
Other questions from committee members? Representative Palazzo.
Thank you, Mr. Chairman, and thank you for taking my question. Basically, the same question you mentioned, evidence-based approach, and I wonder when we are talking about treatment of substance use disorders, like what percentage of people in different programs stop using opioids as a result of participating in those programs that are funded through this method?
So at this time, the first round of funding has just gone out. And so we don't have the tracking of what this funding direct outcomes to that, because this is the very first time we've done a procurement with this funding. But are you asking about how often people go on to get well, essentially?
Like when you choose the best programs, like what outcome you expect? Do you expect like the 10% stop using opioids, or what's the success rate that currently is acceptable?
So the success rates are really very similar to all other chronic illnesses, like diabetes and heart disease, where there are, it's based on, genetics, environmental factors, and the individual and those risk factors. So but depending on the treatment and the individual, tends to be in the 30 to 50% range of, depending on how you define success and how that individual defines success.
Representative Weber, I was just advised by Ms. Dyer, it is an early bill. So this is going to go to finance after. So,
So we can push all of that off.
exactly. Other questions from committee members? I'm seeing none. Okay, thank you very much.
Thank you.
I have no one else signed up to testify on Senate Bill 32. Does anyone else wish to testify? Okay, I'm going to close the public hearing on Senate Bill 32. We have just a couple of minutes before we will begin the public hearing on Senate Bill 34, and we are awaiting the arrival of its prime sponsor. I don't believe Senator Gray is here yet, so. Okay, we'll be in recess for just a couple of minutes. Mike, how you doing? Good, good. Which one is that one? Oh, okay. All right, well. Sure, okay. Right, thank you. Oh, are you, you're not introducing it though, I mean, I'm gonna, no, I'll need a, I'll need a legislator to do that. We'll find somebody.
If you need
Yeah.
Okay. All right, if you don't mind, yeah, we'll give him a couple minutes and then I'm sure he's got 18 places to be this time and begin the public hearing on Senate Bill 34. And I'll recognize the prime sponsor, Senator Gray. Good morning.
Thank you, Mr. Chair. My name is James Gray. I represent Senate District 6, which starts up in the Gilmanton-Alton area and goes down Route 11 to Rochester. I'm going to make this short and sweet. I know that the department provided me a whole bunch of bullet points, but I'm going to let them speak to it. Many of the bills that we deal with, and especially the, if you look at percentage wise, we fix little things that we missed, when we did the bills in the first place. And again, this bill does a lot of that. When we shifted the program from OPLC back to the department, there is a few things that we need to clean up. And certainly the department is here to talk about those. And because my voice is what it is, I'm going to stop there unless there's any questions from you individuals.
Any questions for Senator Gray? I'm seeing none. Thank you, Senator.
Thank you.
Sure. Also signed up to speak is Michael Holt from the Department of Health and Human Services.
Thank you,
Morning.
Mr. Chair. Members of the committee, my name is Michael Holt. I'm a section chief who oversees the prescription drug monitoring program for the Division of Public Health Services. This is department requested legislation regarding the PDMP. So the background of this bill is that on July 1st, 2021, the PDMP was transferred from the Office of Professional Licensure and Certification to the Department of Health and Human Services via House Bill 2. And since that time, we've identified some remedial needs for some remedial legislation. So this bill is a cleanup bill with a number of technical fixes that were overlooked in the transfer from OPLC to HHS. Senate Bill 34 proposes the following. It replaces instances of program administrator with commissioner to reflect the appropriate entity for regulatory enforcement, consistent with other programs run by an executive branch agency. It corrects the name of the Governor's Commission on Alcohol and Other Drugs with regard to the PDMP Advisory Council membership. It transfers two provisions of law back to OPLC, which were transferred to DHHS in error, one having to do with the definition of chronic pain, and the other having to do with prescriber competency requirements. Those are more appropriate to have remained with OPLC. OPLC is in support of those changes. I don't believe they're here to testify, but they send their regards. And lastly, and perhaps most importantly, what the bill does, it allows the department to release aggregate de-identified PDMP data by county. When the program was transferred via House Bill 2, a provision was added that added a very strict confidentiality requirement, a specific site to a specific HIPAA provision, known as the Safe Harbor Standard. And what that requires is that that requires that data cannot be released except on a statewide level, with one exception. We are allowed to release data based on zip code, the first three digits of a zip code. So what you see in the handout is a visual of that zip3 mapping over the state, and you can see that it is not aligned with any county lines. And so the request here is to allow us to allow the department to release de-identified aggregate data by county, like the PDMP has historically done, and so that data can be used effectively with other county level data. So that's the bill. It's remedial. I understand that Representative Merchant may have an amendment to this bill regarding the first point, a program administrator to commissioner. We've worked collaboratively with Representative Merchant, and I believe the language he has in his back pocket is agreeable to us as well. But I'm happy to take any questions regarding the
So would this be
legislation.
considered kind of like a housekeeping bill?
I would absolutely consider this a housekeeping bill. Oh, I'm sorry.
Is that not a good word? Okay.
I didn't know that was a laden term.
I didn't either.
Superstition.
Okay. Sorry. Representative Weber.
And my apologies, I'm behaving badly here. It's just, we have had in the past many housekeeping bills which turned out to make significant programmatic changes. So it's always a little bit of a red flag for us. But I know that my county is 6th from the top in population. I assume that Coas is the smallest county. Do you know what the population of Coas is? Is it over the 20,000?
It is over the 20,000, yes.
I should know that, but thank you.
Right. Interestingly, if I may, we do have a Zip 3 designation that is under 20,000 people, which makes releasing Zip 3 data even possible, because the allowance is to release Zip 3 data for areas that have under more than 20,000. So even under this law, the current scheme, we can't release that data.
Other questions, Representative Merchant?
First a comment, then a question. I wanted to recognize Mr. Holt for the work he's done on the prescription drug monitoring program. We don't always see eye to eye, but I think collectively a lot has been accomplished, and this is an example of that. What I did work with Mr. Holt on, and also Mr. Williams, is where it said program. My concern was who in the program is going to be the one to sign a release, because it's too broad. What we agreed on, I think, is to have designated program staff. So the commissioner can designate somebody in the staff to work on her behalf, or his behalf, and not have it sort of open-ended. And that's kind of the language we have come to, I think, an agreement on.
That's correct.
Thank you. Other questions? Yes, Representative Murphy.
Thank you, Mr. Chairman. Thank you for taking the question, Mike. I would agree that everything that was mentioned above seems like a housekeeping, update. But the last bullet, is that consistent with federal HIPAA protocol when releasing data by counties and other states, or how does that work elsewhere? Is that something that was missed and we are just catching up with the federal standard for HIPAA, or not?
When the program was transferred from OPLC to HHS, a provision was added to the law which required compliance with the safe harbor standard for HIPAA. So that was a change. However, once we tried to implement that, it became clear that that was not something that would work with all of our data, because we need to release this at least by county data. So it is there are multiple levels of HIPAA standards. The one in the law is the safe harbor standard. This bill still establishes that safe harbor standard, but allows for a carve out with regard to locational data to allow us to release that by county. So I would say that it's a bit of a mix of a standard HIPAA standard and a New Hampshire version of maintaining that standard with a carve out.
Just quick follow-up. So it's technically then a quasi housekeeping type of change in the bill?
I hesitate to use the term.
I know. Okay, well, thank you.
You're welcome.
Other questions? I'm seeing no other questions. Okay, thank you.
Thank you very much.
I have no one else signed up to testify on Senate Bill 34. Does anyone else wish to testify? Seeing no one, I am going to close the public hearing on Senate Bill 34. The next hearing will be in about 3 minutes at 10:15 on Senate Bill 87.
thought you were pushing the envelope with that 15 minutes, but
Well,
What time is it?
the chair and Ms. Dyer tend to chat and
yeah, that's exactly.
discuss and
Okay, we're going to reconvene, and filling in for Senator Ward is Daley Frenette from the Senate staff to introduce Senate Bill 87. Good morning.
Good morning, Chairman McDonald and members of the committee. My name is Daley Frenette, and I am the Senate Majority Caucus Director. I'm here today to introduce Senate Bill 87 on behalf of Senator Ward. Senate Bill 87 allows certain nurses to practice in youth camps, organized recreation, and community-sponsored recreation settings. The intent of the bill is to allow fewer restrictions on nurses and other medical personnel that work in the youth recreation camps in order to combat the ongoing healthcare workforce shortage in New Hampshire. The amendment to the bill clarified some of the definitions and standards that need to be met by those medical personnel. Senate Bill 87 was unanimously voted ought to pass with an amendment on the consent calendar by the Senate. So thank you for allowing me to speak today. I appreciate it. Senator Ward is in Senate Education right now, so I will defer any questions to the advocates behind me.
Okay, thank you.
Thank you.
Okay, also signed up to speak is Henry Vayu from the New Hampshire YMCA.
Thank you, Mr. Chairman. I was intending on having these folks go first.
Oh,
I'll submit the written testimony.
okay.
I think they go into great detail. Explain the New Hampshire YMCA support this as an effort to help with the nurse situation shortages at the summer camps. But I will let those folks know.
Okay, sure. Okay, also signed up to speak is Stephanie Castles for New Hampshire Camps. Everyone's deferring to you, so we're looking to you for all the answers.
Thank you for allowing me to speak today. My name is Stephanie Cassells. I'm a resident of Tufton Borough, New Hampshire in Carroll County. And I'm here representing New Hampshire Camps Association as a board member, and we are in support of the bill. I'm a co-director and the medical director of YMCA Camp Belknap in Tufton Borough, New Hampshire. My camp serves 1,200 kids each summer on Lake Winnipesaukee. I'm also a nurse practitioner at Dartmouth Hospital in Lebanon, New Hampshire, and additionally I serve as an advisory board member for the Alliance for Camp Health, which is a national organization. So today, New Hampshire Camp Directors is in support of the bill. Camps are vital to the support of youth right now. New Hampshire serves 150,000 kids in the summer through summer camp. We have over 100 member camps. Nurses are really key to the health and safety of our community in summer camp, and camps are required by DHHS to have nurses on staff. And so we've worked closely on this bill with the Nurse Association and agreed to the language in the bill. The bill is a continuation of a policy and law that has already been in place for the last several years with the pandemic, Senate Bill 277. We see this bill allowing camps to continue to get qualified nurses quickly. Really, being a healthcare professional as well as a camp director, I'm acutely aware of the staffing challenges. You are all aware of, it's hard to get nurses at this point, and the cost is high. And so camps are particularly challenged because we are seasonal, and we are having to be more flexible in terms of how we're bringing nurses in. So it might be for a week or a weekend that we have a nurse on staff. And it is really essential that we're able to get that nurse licensed as quick as possible. We don't have several months leading into sometimes bringing those nurses into camp. And this, our hope is this will help continue that previous Senate bill to allow nurses to get licensed quickly. Open to questions.
Thank you. Yes, Representative Cushman.
Thank you. This is just a simple question. In the analysis of the bill, it says nurse practitioners, but I think it means practicing nurses.
Yes.
Okay. Thank you.
Other questions? Yes, Representative Weber.
So if I'm reading the bill right, what it does is it allows retired nurses who retired in good standing and have kept up continuing education requirements to perform these duties, and it also allows not yet qualified nursing students under certain circumstances to also perform the duties. Is that correct?
Correct. The second part of the question with, they're not yet licensed, right? So the concept is, again, you can see that there's a supervision aspect put in there for them as well.
And that would be my follow-up question, if I may, Mr. Chair.
Sure.
The follow-up question is, it says that they are, I've lost my place here, directly supervised while providing healthcare services. Does direct supervision require the supervisor to be on site, or what exactly is contemplated by direct supervision in this instance?
Yeah, so I think that
The employed by part is understood.
I'm not
but-
sure I have a good answer to that. I think it definitely, you're correct, it does leave probably some interpretation, and the Nurses Association probably, right, would have some idea around what would be.
I'll save it then. Thank you very much.
Representative Merchant.
Thank you, Mr. Chair, and also thank you for taking the question. I understand today OPLC can issue a temporary license for up to, I think it's 100 or 120 days. If they can do that today, then why do we need this bill?
So right now, the Senate Bill 277 is in place till June 30th, and then that goes away, and they won't be issuing to camps. Unless, so
I'm looking at the RSA 310A, and it talks about issuing temporary licenses.
okay. I'm not sure. I'm totally aware of. I do know prior. Is that something that was in the last 4 years?
It was authorized according to this on July 1st, became active in 2021.
Okay.
So I'm not saying not to do this, but
Yeah.
one of the other concerns that I have, Mr. Chair,
Sure.
is I understand about nursing students. I want to follow up on Representative Weber's question. As a student, is the supervision of it. I'm concerned about having a student who hasn't passed their exams yet and what kind of supervision they're going to have, because they probably, of all the people on this list of people who can do this, need more supervision. And I think having somebody remotely supervising them, I find problematic if they're not literally on site. So that's just.
Other questions? Yes, Representative Murphy.
Thank you, Mr. Chairman, and thank you for taking the question. I'm not sure what division or department you practice in at DH right now, but my question would be, is there a particular expertise that's required for a camp nurse? So if you're a rheumatology nurse practitioner, you may not be familiar with bug bites or, allergic reactions or broken bones. I mean, there's a spectrum of the kids' pathology that may come in.
Yeah.
And I wasn't sure if the camp nurse has any, I wouldn't say specialized, but any differential training that's required to get into the camps?
So there isn't specific training that is required. In terms of the hiring process, you would, camps are hiring people who are qualified candidates, right? So I think those people hiring are aware of what's needed in the camp setting as well. So part of this is, right, there's only so much access to a certain number of nurses, and especially, not having all the states in a compact licensing situation. So nurses also have what we call the compact license, where you can go over states, but it doesn't exist for all of our surrounding states.
Thank you. Being very familiar with the camps in New Hampshire, obviously, is there a staff to camper ratio that you have to maintain in these camps? So, for instance, you may have a Coniston which has, I don't know how many, X number, but then you have your camp which has a large number, perhaps on Winnipesaukee. Is there a ratio that you have to maintain?
There's a minimum number of nurses that need to be on site as far as licensing.
Per camper?
Yeah.
Present? Okay, thank you.
Other questions? Seeing no other questions. Okay, thank you.
Thank you.
I have no other cards for people who have signed up. Does anyone else wish to testify on Senate Bill 87? Yes,
May I ask one question for the last?
sure.
Do you mind? Didn't turn this off either, so.
Thank you. So just going back, we were all a little fuzzy on the direct supervision in this bill. So I'm also just wondering, on page 2 on line 27, that where it says that the student has to be employed by or providing healthcare services at the direction of a licensed healthcare facility or licensed healthcare provider. Does that mean that the camp has someone above them? Okay, so
Correct.
maybe some
So
more-
camps are required to have some sort of someone who is putting orders in place. So many camps have a relationship with a hospital or facility, if not a medical director.
Thank you. That helps. Thank you.
Yes. Representative Merchant.
Following up on Representative Cushman's question, having been on the Board of Pharmacy, and the word directly supervised became somewhat of a concern because it was being supervised through technology, not because the person was actually on site. And the board had a concern because if you're remotely available to somebody and something happens, you're not there physically to deal with the problem. Would you be amenable to putting down the individual is directly supervised by an on-site? So somebody's actually physically on-site versus it being interpreted to be through a Zoom.
Through Zoom, yeah. I would obviously have to speak to the organization. I think we would discuss that. I think we definitely discuss though what is directly supervised and how that could look. I think the intent for many of these nursing students would be in camps where we have several nurses, right, at once. So your question around, some of our camps have 4 nurses at a time and some have 1. So the one nurse might, again, not be, is hopefully not the intent, but it's something we should look at.
Yes, Representative Shapiro.
Thank you, Mr. Chairman, and thanks for taking this question. Since it seems to me that these were previously licensed nurses, but that will be given a license, a temporary license once they're hired by, and then will be under the jurisdiction of the licensing board for nurses.
Yes.
Is there any issue with these licenses being provided quickly enough to actually make people available for the camping season?
Well, so that actually, I think, is the issue. The whole intent of this is to help move those along as quickly as possible, because right now, I would say pre-pandemic, we would be 4 months, 4 months of having to submit for a nursing license.
Well, I think we probably get a skewed view, but we hear a lot of, the complaints about, how long these things take. We don't ever hear if they happen efficiently. So I'm just wondering if that would be an issue.
Yeah, and I think that is I would say the pre-pandemic, before we had this language similarly in place for the Senate bill. And again, I don't know the inner workings of the licensing office, but it's been way better, which is why at this point, the camping industry said, wait a minute, like if we could continue doing this would be great, right? Because it has allowed us to not have that headache of like, oh my gosh, our nurse is trying to get licensed 4 months ago and we're about to start camp and we don't have a licensed nurse.
So this would improve that?
Yeah.
Thank you.
Representative Weber, did you have a question?
No, I think either Representative Orchard or Representative Shapiro.
Okay. Sorry, I didn't mean to skip over you there. Any other questions? Okay, I think we're done again.
Thank you very much.
And again, does anyone else want to testify on Senate Bill 87? I have no one else signed up. If not, then I am going to close the public hearing on Senate Bill 87. We're being very efficient so far today. And the next hearing is not scheduled until 10:45, so we'll be in recess for 15 minutes, at which time we will reconvene and hear testimony on Senate Bill 171. Thank you. Okay, I'd like to reconvene and open the public hearing on Senate Bill 171 and recognize the prime sponsor, Senator Ricciardi. Good morning.
Thank you.
Good morning, Mr. Chair and members of the committee. For the record, I'm Denise Ricciardi from District 9. I represent 13 towns, Bedford where I live, and then south and west upwards. I'm here to introduce Senate Bill 171, which is relative to the definition of youth recreational programs, of which I am the prime sponsor. Senate Bill 171 makes a very small change that will have a significant impact on our child care in the state of New Hampshire. The legislation in front of you allows recreational programs such as those chartered by the Boys and Girls Clubs of America, YMCAs, and YWCAs, who offer before and after school care programs to be able to serve our school-aged children. In the early 1990s, the legislature adopted a child care licensing exemption for recreational programs who served children 6 years of age or older, uniquely designed to accommodate the child care needs of working parents while recognizing the enhanced safety protocol and staff training requirements of these national organizations and its enactment. The threshold age of 6 years was considered appropriate in light of the expected age of children who needed supervision before and after school. However, since that time, the state has allowed communities to enact full-day kindergarten programs that enroll school-aged children who may be younger than 6 years. As a result of the inconsistency in these two age limits, the Boys and Girls Clubs and their fellow recreational programs are not able to accept some of the children of families that the recreational program exemption was designed to benefit, even though the characteristics of the need and the program offered and qualifications of the provider are essentially identical. As you all have heard and seen anecdotally, the need for additional capacity in our child care and before and after school space it's at an all-time high. We believe that this meaningful change will give parents and caregivers another source of quality programming that will allow them to maintain employment and stay in the workforce. Today, you will hear testimony from providers who think that this is common sense enhancement to our statute and from families who would benefit from the change. It's for these reasons that I ask you to find Senate Bill 171 ought to pass. Thank you.
Thank you. Are you taking questions, Senator?
You can ask me some questions, but I do have the experts behind me. If I can't do a good job for you, we'll have them come up.
Okay. Any questions for Senator Ricciardi? Representative Weber.
I just had one. What are we contemplating by the term school age, which is the nub of this bill? Are we talking kindergarten on, or if there are, I just wonder if we could have a more precise statement about what we're talking about there.
This would allow 5-year-olds as versus waiting to be 6 years old. And we did meet in the summer with Doreen Shockley from the Department of Health and Human Services, who was very supportive of this bill and actually loved the idea of bringing it forward.
And
follow up.
I'm wondering, I'm very supportive of the intent. My concern is the actual language. So would you have an objection if we changed it to say 5-year-olds so that we know what we're talking about? Or then maybe I should hold that for other people.
I think you should, if you don't mind my suggestion of waiting to hear all the testimony.
Okay.
And see if you don't get an answer that satisfies you better. Would that be okay?
Yep, sure. Thank you very much. And thank you for the answer.
Of course. Yes, okay.
Other questions? Okay, I'm seeing none. Thank you very much.
Thank you very much.
Also signed up to speak is Diane Fitzpatrick from the Boys and Girls Club of Manchester.
Good morning, Chairman,
Could you put the microphone on, please? Thanks.
Good morning, Chairman and members of the committee. I am Diane Fitzpatrick, the CEO of Manchester Boys and Girls Club, and I'm here today to provide a testimony for support of SB 171, legislation our club has approached Senator Ricciardi for. We thank her for all her support with this. We strive daily to provide a culture that welcomes all and gives kids from every background a sense of belonging. There are no barriers of membership or no limits that our kids can't achieve. The Boys and Girls Club of Manchester was established in 1907. We continue to evolve our programs to meet the needs of our community. Our morning program serves over 200 children. We transport them to schools. Our afternoon programs serve over 400 kids, and that includes transportation. Our programs are more than just a recreational program. We provide breakfast, snack, dinners for our children. Also, we provide free food Fridays for families that need access to food. Our afternoon programs include academic support, STEAM activities, performing arts, and the gym activities. The Senator has stated that youth recreational statute was established in the 1990s. Legislators recognize the anatomy of programs offered by the Boys and Girls Club, the YMCA's, Girls Inc. Incorporated. The robust child safety standards that are required by our national parent organizations provide such safety and support for our children we serve. When the law was considered, most children entering school age of 6 entering first grade. Since then, communities and families are embracing full day kindergarten, and the children's age is of 5. With increased before and after school care that we see firsthand, that SB 171 makes a critical change to the statute that will allow us to serve our families better. Not only this current statute makes a child feel excluded when their siblings are currently enrolled in our program, it prohibits them from attending, but also requires families to scramble for alternative childcare. Recreational programs are a critical component that allows families to work, as well as enriching activities for our kids. New Hampshire residents need help finding essential childcare, high caliber childcare across our state. As we move forward away from COVID-19 and a return to normalcy for both parents and their careers and children with their peers is critical. According to the most recent data that was provided by After School Alliance, for every one child in an after-school program in our state, there are 2 on a waiting list. While this is not a silver bullet, we believe that SB 717 will be another tool of helping New Hampshire effectively chip away to the child care accessibility issue. I want to thank you for your consideration and respectfully ask you to this bill ought to be passed. I'd be happy to answer any questions, as well as I have letters from parents that support this bill.
Thank you. Representative Weber.
Thank you, Mr. Chairman. I've now formulated better my question to the senator. What my concern is if we have different districts that have different offerings, and once again, this is a child care bill that came to us for reasons that I don't understand because I don't have expertise in this area. But if we have different districts that are offering different schooling programs at different ages, do we want to tie the language of this bill to school age, which might vary from district to district, or do we want to have it age specific? And that's a question that I'm asking because my town, for example, offered full day kindergarten for a decade and a half before kindergarten was even required. Right. But other districts very close by did not offer kindergarten at all. And so in those contexts, what is school age?
I think it's
and I don't know whether that's even an issue or not. So that's really what I'm asking
No,
to,
I think it's an excellent question. Before we even proposed this bill, we met with childcare licensing. So we are license exempt. And what we're asking is if we can, it is school age. So in our community, school age would include 5-year-olds going to our Manchester School District. So I think if we use that language, it would meet the needs of those districts. But the childcare licensing is in favor of this and recognized that this legislation was written in 1990s, and we have continued to evolve our after-school and childcare. Did that answer your question?
If I may have one follow-up?
Sure, follow.
So what I think you're telling me is you would prefer the language school age to anything more specific because it might float.
I would like it to float so I can serve more families. And if it's recommendation of the committee that you'd like to say school age, including kindergarten. I think the key word here is kindergarten.
Well, what I'm trying to drive at is and I don't even know if there are schools here who do this in New Hampshire, but if a school established a pre-kindergarten program, those children in that district would be school age. So,
yep, you've got to.
And I am all for inclusivity, but I'm wondering if it was contemplated that there would be no floor on the ages just based on differing needs of kids, or whether I'm just looking at wordsmithing as to whether what we need is the word school age or whether we need 5-year-olds. And I guess my other question would be, do some school districts, and I'm hoping somebody behind you will actually answer this if you don't know the answer, do some school districts admit kids who have reached their 5th birthday? Some, when I went to school, there were some that started if you were going to be 5 by December, some you had to be 5 by September. So it was a different age for every different school district. And is that the case now, and does it matter? And I'm just trying to educate myself and then find the right words. So if you're not the right person to
If you don't mind me
understand.
responding.
Sure.
I believe, and I'm not, this is just from my experience with education, I believe it's September 30th. The child needs to be age 5, entering kindergarten. If the language of this bill could say 5-year-olds entering kindergarten, that would clarify everything. Any preschool programs, if the Boys and Girls Club of Manchester was to offer that, we would go through childcare licensing and get our program licensed. What we're looking at is kindergarten, 5 years old and up, to enroll in our morning and after-school programs.
Okay. Thank you very much. I appreciate that.
Representative Shapiro.
Thank you, Mr. Chairman, and thank you for taking this question. So I assume that the way statute is currently written, that if someone was 5, they couldn't go to your program, they'd have to go to a program that was licensed as a daycare program.
Yes.
Okay, so what are the differences in standards in terms of, I'm not asking you to give me every difference, but what are generally speaking, what are the difference in standards for being licensed as a daycare versus being licensed as a recreational program? Because we will be sending younger kids to you, and do the standards meet their needs, basically?
Excellent question. Yes, they do. And I think it's ratios. So when you think about ratios, my background, I was a kindergarten teacher many moons ago. So we want to make sure our kids have accurate ratios. For our licensing, we're license exempt, but we do have to follow Boys and Girls Club of America's safety procedures. So all our safety ratios, all of those requirements, if you compared our requirements and compared it to childcare licensing, they're very similar. So, instead of going through the state licensing, we're going through Boys and Girls Club of America, just as the YMCA. But there are programs, if we were to offer a preschool program, I would go and be childcare licensed, and the ratios would be smaller.
Follow-up?
So that means that the major difference in your mind is the ratio of children to adults. So your program is under federal, under guidelines that are like countrywide. So, but there might be programs that don't have those kinds of guidelines. So the ratios might be different?
They could be different. I couldn't speak for all, but when you really think about the program we're talking about and our particular organization, but I agree across the board, we're all very in tune to what the needs are of a 5-6-year-olds and making sure we have adequate ratios as well as safety.
Okay, thank you.
You're welcome.
Other questions?
Yes.
Representative Merchant.
Thank you, Mr. Chair, and thank you for taking the question. It's a follow-up on Representative Weber. My concern is when we use the word school-aged, there's no floor to it. School is to be defined. Preschool and so forth, et cetera, whether they're going to be included here or not. Am I hearing that you would be amendable to change things to write 5 years of age at the time you enter kindergarten? At least at that point in time, this definitive amount does two things. One is there's a floor to it, we all understand. And number two, it's a standard across the whole state.
Absolutely.
Thank you.
Other questions? Representative Cushman.
I'll retract my question and I'll take it offline, actually. With
Okay.
the representative.
Okay, thank you. Other questions? Seeing no other questions, thank you.
Thank you so much for your time.
Also signed up to speak is Doreen Shockley from the Department of Health and Human Services.
Good morning, committee chair, members of the committee. It's a pleasure to sit here before you today and hopefully clarify the questions regarding the school age program definition. What we did when we met, what seems like a very long time ago, but the school age program, a school age program is currently defined in RSA 170E:2 and includes children who are 4 years and 8 months of age or older. Is that helpful?
Thank you.
Mr. Chair.
Any more questions?
Sure, are you taking questions?
Okay.
Are you concluding your testimony or did you have more to say?
No, I just wanted, no, I have no testimony. We were here in support of because we met, but because there were so many questions regarding the age, I thought I'd clarify that.
Representative King has a question.
Yes, just can you give me that RSA number again?
Certainly, RSA 170-E:56.
Thank you.
No, I'm sorry, that's a different one. 170-E:2 defines school age program.
Okay.
And there we give the age.
All right.
Representative Shapiro.
Thank you, Mr. Chairman. I'll ask you the same question that I just asked, basically, which is we're bringing younger kids into a program that currently they have programs have to be licensed in a different way. So from your point of view, will the change in standards, which were referred to mostly as ratios of adults to children, will they be adequate for younger kids?
The ratios are also described in rules as to the number of adults per child based on child ages. So those would still need to be adhered to. This is really, I don't want to use the word housekeeping. I saw what that did last time. But this is really, we were thankful that they brought it to our attention that we have two separate sections of RSA that are in conflict. So this is right size and making sure that they're the same.
Okay, so the ratios really are still the same
Still
for
the
the
same.
same age kids. Thank
Correct.
you very much.
You're very welcome.
Representative Weber.
So would we, am I correct in thinking we would solve both your needs and my wordsmithing problems by simply adding school age as defined in 170-E:2?
We would be certainly amendable to that as
Okay, and that way we have the direct reference to where in the statute it's defining it.
Absolutely.
Thank you very much.
Thank you.
That would solve all my.
Other questions? I'm seeing no other questions.
Thank you.
I have no one else signed up to testify on Senate Bill 171. Does anyone else wish to testify? Seeing no one else, I'm going to close the public hearing on Senate Bill 171. And I am going to open the public hearing on Senate Bill 240 and recognize the prime sponsor, Senator Prentice.
Good morning, Chair McDonald and members of House Health and Human Services. For the record, my name is Sue Prentice. I'm the state senator from District 5, covering a large part of Grafton, some communities in Sullivan, and one community in Merrimack County, the beautiful town of New London. So Dartmouth Health has asked me to introduce Senate Bill 240 to forward or in really ease the navigation of care. This bill would make a change to RSA 141H2, the statute that governs conditions for genetic testing. Senate Bill 240 would allow for a healthcare facility to disclose genetic testing or lab results to clinical entities participating in processes related to clinical care or research for the patient. For example, this would allow a health facility work with a clinical entity to find an innovative protocol for a patient that's navigating cancer treatment or navigating treatment of Lou Gehrig's disease, ALS. I do have a representative from Dartmouth Health here that's also going to be able to testify about the impact and the change for patients in this process. But I want to add, in addition to my introductory comments, two pieces. Number one is that, well, first of all, right now, the way the law stands, all we can send to these entities that do matchmaking with, like for cancer patients and for Lou Gehrig's disease patients, do matchmaking for protocols for their care to, hopefully save their life, improve their outcomes. All we can send is tissue or tumor. We're the most restrictive state in terms of sharing this in New England. By making this change in the law, we would be able to actually send the results and the analysis that facilities like Dartmouth Health are able to do. So that is really what this change does. That's number one. And number two, I want to speak to consent. Patients are consented for this type of testing. However, concerns have been raised. They were raised in the Senate, and I want to bring them up here and work with this committee on the research part of this. We're going to need to make a change to have make sure that it's clear that if you are going to, if that patients are consented if their information is going to be used for research purposes. So that I'd be happy to work with members of your committee on. But with that, I'll end my introductory comments. I'll take questions that I can answer, and if not, again, I do have a representative from Dartmouth Health, and I would be willing to get back in touch.
Okay, thank you. Questions? Any questions for the senator? I'm seeing none. Okay, thank you.
Okay, thank you very much.
Actually, I have no one else signed up to testify. Does the person from Dartmouth Health want to testify? We do need a pink card from you. Okay, thank you. And please put your microphone on. Thank you.
Good morning. For the record, my name is Courtney Tanner. I'm the Director of Government Relations at Dartmouth Health. So as Senator Prentice noted, the statute as drafted currently restricts the disclosure of genetic testing results to other clinical entities, including healthcare partners in which we have a formal relationship with. So this restriction unintentionally prohibits a New Hampshire healthcare entity from matching our cancer patients or other types of patients with treatment protocols that involve the use of genomes. To create efficiencies, sometimes entities like Norris Cotton Cancer Center or Dartmouth Health Medical Center, we are using a third-party entity to match patients with the appropriate treatment protocols. This requirement, as it stands in current statute, is a barrier to accessing timely care for our patients in New Hampshire. A similarly situated patient in a different state would not have to face this hurdle. Senate Bill 240 doesn't change New Hampshire health systems consent requirements or our consent processes. Our providers and patients will still have to engage in informed consent practices, consent to treat, consent to engage in research. All healthcare systems and clinical entities must comply with HIPAA. This bill does not change that either. And we have robust checks and balances to ensure that the appropriate research disclosures are completed and discussed with the patients. However, as drafted today, RSA 141H2 treats genetic testing differently than it does for other health than other health information. For example, tissue treatment. Senate Bill 240 removes an administrative barrier for providers, but more importantly for our patients, so that a provider can work with their care teams to identify the right treatment protocols for patients and coordinate patient care. So I am not a provider. I have an orange badge. I am not a doctor, but I just wanted to highlight two examples of where we see the statute today creating barriers to care. First, today the statute doesn't allow, as Senator Prentice noted, it doesn't allow us to work with clinical partners to find treatment protocols based on genetic testing results. An example of this is there's a BRCA gene. This is a gene that is found in patients that are at risk for breast cancer. I see Dr. Murphy shaking his head, so that's helpful. Thank you. This knowledge can be used. The knowledge of the existence of a BRCA gene can be used to detect risk for breast cancer, but right now, our providers can't communicate the presence of that gene without circling back to get additional consent from the patient. So we can't communicate the presence of that gene. We can't even communicate that genetic testing was done for this patient with our clinical partner. When a provider wants to talk about case review their patients with their research colleagues, they can't even disclose that genetic testing was done. For example, if we have an oncologist who's working with ovarian cancer patients, we can't even disclose that the existence of the BRCA gene, which is my understanding, again, I'm not a provider, that the BRCA gene is also can be an indicator for ovarian cancer risk. We can't even disclose that gene exists, or that the genetic testing was done. And this is different than tissue treatment or how we treat any other testing in the healthcare system. I'm happy to take questions. I'm also happy to take questions back to our care team, who are much more qualified than I am. But that is the close of my testimony.
Thank you. Questions? Yes, Representative Merchant.
Thank you, Mr. Chair. Thank you, Ms. Gordon, for taking the question. One of the things I've heard about, that's come to my attention, is the use of genetic testing in regards to coverage for medical care or insurance policy and so forth. My concern is that if you look at line 8, it goes to either clinical care of the patient. My concern is someone misinterpreting that and saying it could go to an insurance company for them to decide upon whether you qualify for pre-existing conditions and so forth. That's my concern. Can you address that for me, please?
That is a question I'm going to have to take back to our team. I would just note that we don't this as drafted today, as the statute stands today, we don't treat other types of testing results the way in such a restricted way that we do for genetic testing, and those concerns don't exist for. Again, I've used this example over and over again, but for tissue testing, for example. So I don't know that concern would exist, but certainly happy to circle back with you on that.
Follow up.
Would you just, when you talk to the team, be sure that there's guardrails on this information so it does not become used against the patient for qualifying for medical care? And that's where I'm trying to get to with prior authorizations and so forth. What's there? I just want to be sure that information is in fact staying within the clinical team, treating the patient, not somebody who's paying the bill.
Yeah, absolutely. I mean, so I would just note that this all health information is HIPAA protected, right? So we would have to be mindful of that too. That doesn't change those practices and policies.
Thank you. Representative Weber, and then Representative Murphy.
Thank you, and thank you for taking my question. I'm now really bewildered because isn't a patient allowed, when they sign an informed consent form, to allow the release of whatever information they choose to release to whatever entity they choose to have it released to already?
Yes, but as interpreted currently, RSA 141 treats genetic testing differently than other types of testing. So it would require an additional explicit informed consent again, or consent to release information again, if there needs to be care collaboration. That's the interpretation of our legal counsel.
So could I have a follow-up, Mr. Chairman?
Sure, follow up.
But my question is, if we're releasing sensitive information, which as Representative Merchant has noticed, might be used for purposes that we're not wanting it to be used for, isn't the remedy simply to ask for the specific release from the specific patient? And isn't that a good thing rather than a bad thing? And therefore, why would we want to get rid of it?
I think it is a good thing. I think the concerns, again, because we're treating this type of information differently, I think the concerns come when it's not moment in time. So when, say, a new treatment protocol comes out and researchers want to go back and look at their patient profile to say, okay, this new treatment option is available. Let me look back to see if I can look back to see who has the BRCA gene or other types of genes that are found in genetic testing only. That type of look back can't even be done. They can't even go back and circle back with their patients.
But can I have one further follow-up?
One follow-up, yeah, another follow-up, sure.
That's okay.
But wouldn't the treating physician be able to say to their patient, oh, gee, there's a new protocol. May I release your information to see if you're appropriate for that protocol? I'm having a hard time understanding why that's such a problem.
That would be ideal, Representative Weber. The issue is that a treating physician and a researcher, they're not even able to communicate that, the treating physician's not even able to communicate that genetic testing happened for that patient with the researcher. So there is this gray wall or barrier that exists right now for this type of testing.
Representative Murphy?
Thank you, Mr. Chairman. Thank you for taking the question. So I just want to be clear. This would allow providers, say at DH, to refer patients to other clinical institutions, say, that have different protocols and different treatments that they're doing that is not done locally. Is that correct?
Referrals, and also allow us to communicate with our third-party entities to help us find the appropriate protocols.
Okay, just follow up. So it's not just the third-party entities, it's also the potential treating facilities that may have different expertise and with whom we can share the patient's clinical information, but also their genetic testing and analysis. Is that correct?
That is correct.
Thank you.
Yeah.
Other questions? Okay, seeing none, no more questions.
Thank
Thank you. And don't forget the pink card, please. Also signed up to speak is Mike Rollo from the American Cancer Society.
Thank you, Mr. Chairman. For the record, Mike Rollo, American Cancer Society Cancer Action Network. In support, after listening to some of the questions, I may have to reconsider because I'm not sure I want to testify, but we are in support. I think from the very beginning, I want to just stress how important patient privacy is to our organization and how serious we take that. I think where we are in support really comes to what Representative Murphy has just opened up to the conversation, where this could potentially open up access to additional clinical trial options for patients. This, to us, is about access to care. It's potentially opening up access to different treatment options for patients that may not have other options. Keeping in mind their privacy is of the utmost importance to us. So if there are issues that you all need to work out, I will leave that to you. We're not here to speak to that. Our main goal is advancing research and advancing options for patients. And that's why we would be in support of legislation like this. And with that, I think most of the people behind me probably want to get to the next bill, so I don't want to belabor
You
it.
get that impression, do you?
Yeah, us too, so
Okay.
I'll be happy to take Representative Merchant's question, of course.
Representative Merchant?
Thank you, Mr. Chair, and thank you for taking the question. Would you be willing to propose some language that could be added to this bill to ensure we're protecting the privacy of the patient from undue harm because the information was used in a manner never intended?
And you asked, I just,
Would you be willing to help us with drafting language for the bill to ensure we safeguard the information? So therefore, the information doesn't fall into
of course.
an entity that's going to use it detrimental to the
Of
patient.
course, and I think, I don't want to speak for our friends at Dartmouth, but I'm sure they'd be willing to as
Thank
well.
you.
I don't think they want to see their patients' information go anywhere else. I mean, I think that, from what I'm reading in the bill, I don't think that's going to be an issue, but I just raised it because Representative Weber had brought up the issue of the privacy of the patient. So that's why I bring it up. That's always the first thing we think of is the patient's privacy, but
Other questions? Seeing no other questions, thank you.
thank you.
Also signed up to speak is Representative Neil Kirk.
Good morning, Mr. Chairman. I'm Neil Kirk, former state representative, and I appreciate the opportunity to be here. I live in Ware, and I'm representing myself. I have some material to pass out, if I may.
Sure.
Mr. Chairman, I was involved in the original legislation, RSA 141H, which tries to protect our privacy and our genetic information. When I read this bill, I was a little bit surprised because it seems that everything the sponsors wish to do can be done currently under law with the consent of the patient. Apparently, after speaking with Ms. Tanner, an attorney for Dartmouth has strictly interpreted the language in such a way that even with the patient's consent, they cannot do what they're proposing to do. I find that very difficult to believe, but that's the current situation. The problem with their solution to that is that it broadens the use of material for both research and clinical treatment, and by using the same consent forms as they're currently using, deprives the individual of knowledge of what is going to be done with the genetic material. So when he signs the consent form, he's not fully informed about what he's consenting to. If there's some problem with the bill, with the statute, that makes it impossible for Dartmouth to do the right thing by their patients, by all means, let's check that. But let's make sure that we are protecting your DNA, which once it's gone, obviously, is totally lost, in ways that a normal, reasonable patient who is faced with 37 forms that he has to sign every time he goes to the doctor and which he cannot read, not realistically, except if you're like me, you spend an hour in front of the window reading all of these forms and crossing out things you don't agree with. But I'm one out of 1,340,000 people. Most people don't have time to do this, and it's up to the legislature to act in ways that protect those privacy rights. I will try to work with Dartmouth to come up with some sort of an amendment that satisfies their need and also protects the genetic privacy of individuals. The handout that I sent you was a letter that I had written to Dr. Morrill, who testified in the Senate, asking him the same kinds of questions that I've raised with you. I did not hear back from him. I just had an opportunity today to speak with Ms. Tanner. She seemed amenable to working out some other language and will proceed to do that. So, Mr. Chairman, I hope the committee will not act on this bill until you've had an opportunity to see what Ms. Tanner and I can come up with.
Thank you.
Thank you, Mr. Chairman. I'd be pleased to answer any questions if members have them.
Any questions for Representative Kirk? Seeing none. Thank you.
Thank you.
And also signed up to speak is Courtney Tanner from Dartmouth Health. Oh, okay. Oh, this is the card that you owed us. I'm sorry. Okay. All right, I have no one else signed up to speak for Senate Bill 240. I'm almost afraid to ask, is there anyone else who wants to speak on Senate Bill 240? Seeing none, I am going to close the public hearing on Senate Bill 240 and open the long-anticipated public hearing on Senate Bill 263 and welcome Senator Jeb Bradley, the prime sponsor. Sorry to keep you waiting, Senator. Good morning.
Good morning. How are you, Mr. Chair, members of the committee? So thank you again, Mr. Chair. Pleasure to be here. Jeb Bradley, representing Senate District 3. Thank you for the opportunity to testify in support of Senate Bill 263, which passed the Senate, coming out of the Health and Human Services Committee 24-0, and passed the Senate 24-0 again on a voice vote coming out of the Finance Committee. This is the third iteration, if you will, of authorizing Medicaid expansion. I've been pleased to be involved in all three of the prior pieces of legislation. This bill is, compared to the previous bills, quite simple. It does three things. It makes Medicaid expansion permanent. It reestablishes the Oversight Commission that was repealed at the end of 2022. And it eliminates use of the alcohol fund to fund the state share and substitutes, if needed, liquor fund revenue. What Senate Bill 263 doesn't do is make any changes either to session law or RSA 126 AA that are already established pieces of law in New Hampshire in terms of Medicaid expansion. The eligibility stays the same, 138% of poverty. People are eligible for Medicaid expansion. That's about $20,000 of income for a single individual or $41,400 for a family of four. It uses the same managed care criteria that focus on wellness, on mental health, substance abuse. The work requirements remain in place in state statute, and the taxpayer protection mechanisms that have been part of all three iterations of Medicaid expansion stay in place. And those taxpayer protection mechanisms are a disallowance of general funds to pay for the state's 10% share, a wind down of the program if federal funding comes in at less than the 90% promised share. Those taxpayer protection mechanisms stay in place. So I think the question, I hope that the question that you will ask, that the Senate asked and arrived at a conclusion in a bipartisan fashion, has Medicaid expansion worked? And I believe the answer is a resounding yes. If you look at the package that I've passed out, and I trust that there's one for every member of the committee and one extra, you'll see that in the individual market insurance rates have dropped. In fact, For the targeted population, a single 40-year-old, we have the lowest individual rates in the country. That's a result of changes that we made in 2018. The number of people accessing their health care at the emergency room has dropped. That was also one of the goals of earlier pieces of legislation. Uncompensated care has dropped. Uncompensated care is a tax, if you will, a hidden tax on anybody with private insurance in the state of New Hampshire, whether it's in the individual market or whether it's through their employer. Because what happens when hospitals have to give care, which they're required to do under federal law, at the emergency room or some other setting, and there's no way to be compensated for that, it's rolled into the rates that they negotiate with insurance providers as a hidden tax on whether it's an individual or employers. Medicaid expansion for the individuals that are part of Medicaid expansion is not permanent. Many people have been on Medicaid expansion for a short period of time, and then as their life situation changes, they're able to leave Medicaid expansion and qualify for other health insurance, whether it's through an employer or on the exchange. We actually have the fourth lowest percentage of people on Medicaid of any state in the nation, according to the Kaiser Foundation. Medicaid expansion, as you'll see from some of the fact sheets provided, has provided enhanced services and access to people with mental health issues, as well as substance abuse, and obviously our crises, our dual crises of substance abuse and mental health. It's very important that we maintain those services. And the cost has proven to be affordable. The federal government has maintained its 90% funding requirement, and the state has been able to meet its 10% share without use of general funds, whether it's liquor funds, the insurance premium tax on Medicaid policies, the New Hampshire Health Plan Assessment, and other smaller sources of revenue. So the question I think that you will hear today, and hopefully you will be able to answer, as the Senate answered, have individuals benefit? And I think you're going to hear a lot of testimony from a lot of people. The Senate heard a lot of this testimony about how people were able, with access to health care, to change their lives, to be able to get into the workforce and lead productive lives. You will also see countless letters and support by various business organizations that know that a healthy workforce is absolutely essential for the economy of the state of New Hampshire. And if you look at all of the chambers of commerce that support it, the New Hampshire Retail Association, the BIA, I was given a letter by the New Hampshire Bankers Association this morning. The support among the business community is broad. The only two issues that came up in testimony and discussion in front of the Senate are these two that I recall. Is Medicaid expansion providing an incentive not to work? And I would argue that the opposite is true, which is why you have so many business groups and individuals in support of it. And referring back to the Kaiser Family Foundation study that shows that we have the fourth lowest percentage of our residents on Medicaid. 70% of New Hampshire residents on Medicaid are working. That's higher than the U.S. average of 63%, and only 8%, only 8 states have a higher percentage of Medicaid recipients that are working. So I think in terms of a disincentive, clearly not one. The other issue is the question of making it permanent. And I think that after 9 years, with the taxpayer protection mechanisms we've built into it, the wellness incentives that have been built into it, how it's helped people, how it's helped the business community. I believe it's time to make it permanent, to allow for the most cost-effective contracting with managed care organizations. So, Mr. Chair, at this point, I'd be more than happy to try to answer your questions.
Thank you, Senator. Questions for Senator Bradley? None? Okay. Oh, it's Representative Cushman.
Thank you, Mr. Chairman. Thank you, Senator, for being here and for taking my question. I understand that we have, we've got these reductions in uninsured residents, and I often hear people kind of conflate insurance with health. And I was just wondering if there are real-world demonstrable improvements in the health of Granite Staters as a result of this program.
Well, thank you for the question, Representative Cushman. I think that you will hear the same testimony that the Senate heard from actual individuals who've benefited significantly. And I think if you look at and hear the testimony from the New Hampshire Hospital Association, they will go through the drop in uncompensated care, which, as I said before, is a hidden tax, the drop in people showing up at the emergency room and getting care that don't have insurance. So I think that the evidence is pretty clear. There has been a real world impact on positive health outcomes for people. In 2018, we built a number of wellness incentives into the MCO provision of service. And so the Senate heard testimony from the MCOs, and I think, hopefully you'll hear that testimony today about how these health incentives are actually working and should be a part of our healthcare system. And you, as a healthcare professional, know an ounce of prevention is a heck of a lot better for the individual than all the cures in the world. And if we can prevent illness, that should be our goal.
Other questions? Oh, follow? Oh, I'm sorry. Representative Merchant.
Thank you, Mr. Chair, and thank you, Senator Bradley, for taking the question. Recently, there's been, because of the federal government, there was expansion of the Medicaid program itself, not so much for this medical side of it. And we heard at the Department of Health and Human Services Oversight Committee, the department's going through the process of re-qualifying people for Medicaid benefits. Can you speak to how that may impact those? What I'm concerned about is people losing coverage that we're trying to encourage here, but all of a sudden, because of what's going on with the federal requirements, that they fall off the radar.
So, and I'm sure the department can further answer this question, but to try to put it in a nutshell, because of a federal requirement during the pandemic, if you qualified for Medicaid expansion, you could not be disenrolled if you no longer qualified until the end of the emergency, which was April 1st or March 31st. So New Hampshire has begun the process per federal regulations of disenrolling people who no longer qualify because their income has exceeded the 138% of poverty. So that is a process that will occur over time. The department has estimated that the historic trend, let me put it this way, up until the pandemic was between 50 and 52,000 people, New Hampshire residents, on New Hampshire Medicaid expansion. That ballooned obviously during the pandemic because no one could be disenrolled up to over 90,000 people. The department estimates that that will go back to about 60 to 65,000 people by the end of the year. But part of what the Department of Health and Human Services is doing, as well as the Department of Insurance, is a very vigorous outreach program to those people who no longer income qualify to get them for an opportunity to avail themselves of the health insurance that exists on the exchanges, which in all likelihood they would qualify for, or obviously at this point they may qualify for employer sponsored insurance. So this change was precipitated by the federal requirement to not disenroll during the pandemic, and now the federal requirement that has ended. So it's really outside of what we've created in New Hampshire over the years.
Thank you.
Other questions? Seeing no other question. Oh, I'm sorry, Representative Cushman.
Thank you, Mr. Chairman. Thank you again for taking my question. This one is on the commission to evaluate the effectiveness and future of the Granite Advantage Healthcare Program. So can you explain what changes are being made to that commission in this bill?
It's largely recreated, Representative Cushman. And I chaired the prior commission for several years that issued a report last fall. So it has 3 members of the Senate, 3 members of the House, representative of various departments, Health and Human Services, insurance, representatives of the managed care companies, hospitals, a public member. We've had public members in the past. A public member this time representing the interests of small businesses. I think that's new. We've had a licensed physician in the past. We've had other licensed healthcare professionals in the past. I believe the substance abuse disorder professional is somebody that we haven't had in the past. The nurses, I think, have been represented. The chairperson of the Alcohol and Drug Prevention Treatment, I don't recall if I was a member. I'm doing this from memory, I'm sorry, Representative. But I think it's a broad collection of healthcare professionals, legislators, and state officials at the 2 departments that will provide the necessary oversight on an ongoing basis with a report that has to be written every year before November 1st, on or before. So I think if people are, especially with the thought, hopefully, that this becomes permanent, there should be permanent oversight. And I would like to believe that this accomplishes that goal.
Follow-up.
Thank you for running through that. So I'm wondering, there have been some other study committee bills coming through here, and the actual voting members have been restricted to members of the legislature, and then the other members, like, for example, you know, of the MCOs and public members, they served as advisory or could give input, and we're listed as, you know, we want input from these people, but the actual legislative action taken is by members of the general court. Would you be amenable to such a change?
So as I recall, and I'd have to go back and read the prior statute, but I think that was the case in the Senate Bill 313, which I sponsored in 2018, that had only legislative members voting. As I recall, that was the case. When I chaired it, I tried to take all voices and sort of tried to come to consensus among all the members. So to me, that's how it should work, whether it's specific to legislators only voting or a vote of the entire commission. I think either way worked for me. It depends on, you know, I think just whoever chairs it has to be as inclusive to all voices as possible.
Thank you.
Other questions? Representative Weber.
And just as a follow-up to Representative Cushman's questions, isn't it true that the function of this committee is not a legislative one? It is evaluating, writing a report, and then reporting to the legislature and others so that further action, if needed, may be taken by the legislature at that time.
Obviously, that is what oversight is all about, Representative Weber, and thank you for that question. The point I would make is that this is the 4th version of Medicaid expansion. Any member of the legislature can file a bill at any point in time in the future to make changes, whether this becomes permanent or is something less than permanent. I hope it will be permanent. But clearly, the role of an oversight committee is to provide that kind of input back to and through the 3 senators and 3 House members for the other 418 members of the legislative body. I got my math right. 424 minus 6.
This is why I sit on the Health and Human Services Committee and not the Finance Committee,
That was a
Senator.
pretty easy one. I'm all right at addition and subtraction, sometimes.
Representative Merchant.
Thank you, Mr. Chair, and thank you, Senator, for taking my question. I'm looking through a list of individuals on the commission. It's very extensive. One of the parts that I think could be added to it, drug therapy is a critical component to healthcare, but there's nobody here from the world of pharmacy dealing with the issues that go on with a major cost. If we look at the cost within healthcare, it's probably running 17 to 19% of the cost, but there's nobody there from the world of pharmacy sitting on the commission.
I would take that as a friendly amendment.
Thank you.
Other questions? Representative Cushman.
Last one. Thank you. So thinking now to, we have some people left out from it. I just want to so when we have this exhaustive list, and this was the issue with other study committees and commissions, it ends up inevitably leaving some people out. So that's why I made the point of, leave it open to advisory. But I don't see anything in here that directs this commission to take, and I'm sure that they could, but would you be open to an amendment to say that they take testimony from the public as well?
To me, that always goes without saying, but of course, that would be, I would consider that a friendly amendment also. I mean, when I chaired the commission, we always, made sure to listen to folks. And I know you folks in this committee do that every day, and we try to do that in the Senate. But I would see both of those as friendly amendments.
Thank you.
Other questions? Seeing no other questions. Okay. Thank you, Senator Bradley.
Thank you, Mr. Chair.
A couple of announcements, just to explain how we're going to proceed today. Understandably, we have quite a few folks that want to testify in this bill. It's a very important bill, and we want to make sure you all have an opportunity to give us your input. Accordingly, the only way we're going to do that is if we limit testimony. It's been our policy on major pieces of legislation to let the prime sponsor have extra time because they're going through the details of the bill. But after that, we do ask that those testifying limit their testimony to 3 minutes, and that will be enforced. After your 3 minutes is up, I will, ask you to conclude, or actually, I'll give you a little bit of a heads up as you're approaching your 3 minutes, ask you to wrap up, and then ask you if you're going to take any questions from the committee. Also, as we approach the lunchtime hour, I know that your time is valuable. My recommendation to the committee would be that we continue until we're done, and members can take lunch as they at their own discretion, kind of like a rolling lunch. Does the committee have any objections to that? I know there's a budget informational session later on this afternoon that some may want to attend also. So anyway, any questions at all, committee members especially? Representative Weber.
I just note that this is all taped, so members can fill in the gaps at a later date, unlike our prior procedures.
Okay. I had an extra big breakfast because the vice chairman is out and I have nobody to fill in for me. So anyway, with all of that being said, the first person to testify is Mark Bonta from Genfoot. Okay.
You know that you were free
if you wish to designate anybody to present in your absence,
Oh.
if you would care to do that.
Okay.
Not that you need to, but it's certainly been practiced in the past.
Okay, good to
You
know.
could do that.
Thank you.
My name is Mark Bonta, I'm plant director for Gen Fed American in Littleton, New Hampshire. Can I turn on your microphone?
Again, sir, you were out in the hall, but you have 3 minutes, so.
Okay.
That's fine.
And could you state where you're from again? Because I just didn't catch it.
Yeah, I'll start over. Yes, sorry about that. My name is Mark Bonta. I'm the plant director for GenFood America in Littleton, New Hampshire, and I've been on the State Advisory Council for the Recovery Friendly Workplace since 2018. Very passionate about the RFWI, mostly because back in 2011, I had fired an employee for reporting to work under the influence of alcohol. And tragically, within 6 months of losing her job, she passed away of liver failure because she couldn't stop drinking. When I learned about the RFWI, it helped me to realize that there are other options that I could have taken with an employee that has a substance use disorder, helping them get into recovery instead of firing them namely. So in the past 5 years, I've come to realize that anybody that has a strength of character to beat addiction is somebody that I want working for me. So I've been working directly with a recovery home local in Littleton, and I've hired dozens of employees from that pool of applicants. Some of them didn't work out, but some of them did, and some of the success that can be attributed in large part to the support that Medicaid expansion gave them during the first few months of recovery. When we hire new employees, and this is most companies, there's typically a 3-month probationary period where they're not yet eligible for health insurance. And that first few months of recovery is crucial to anyone getting into recovery because they absolutely have to have treatment in order to get the recovery off to a good start. And somebody needs to pay for that treatment to fight addiction. The Recovery Friendly Workplace Initiative in New Hampshire is now 330 workplaces and over 90,000 employees strong, and the positive progress is evident. You can see it in some of the data that's coming out in regards to overdoses and such. We are all working really hard to battle addiction, and we're winning the fight, but it's not over yet. There's still a lot of work to be done, and we need the support that Medicaid expansion gives us to continue the positive progress we've been making. So please vote to continue that support for us on a permanent basis. Thank you.
Thank you. Questions?
Nope. Questions?
Any questions for this gentleman? Yes, Representative King.
On your card, you have that you have 20 copies of your testimony. Did that make it around already?
I don't remember putting that on a card. Was that something that we've received so much? I'm not sure.
Okay, thank you.
Yeah. Okay. Other questions? Okay, thank you, sir.
Thank you.
Also signed up to testify is Steve Anand from the New Hampshire Hospital Association and John Skevington from Parkland Medical Center. It's my understanding, gentlemen, you wanted to come up together?
If that's okay.
Sure, absolutely. So again, 3 minutes. You each have 3 minutes. I think it's H-N-E-N, I think.
So let me give you half of yours.
Good afternoon, Mr. Chairman and members of the committee. Thank you for the opportunity to come up and testify with John jointly. My name is Steve Anand. I'm the president of the New Hampshire Hospital Association. I'm here representing all of our state's hospitals. John Skevington, as you noted, is the CEO of Parkland Medical Center in Derry. You have my written testimony, so I won't go through it in its entirety, but there are a few points that I would like to make. New Hampshire's hospitals have been and continue to be partners with the state in caring for our most vulnerable citizens. It is our mission to care for those who are sick, and our members work tirelessly to provide the highest quality care to all of our patients, regardless of their ability to pay. New Hampshire's hospitals strongly support our Medicaid expansion program.
Coverage to the Granite Advantage Healthcare Program allows patients to be seen by a primary care doctor or in a health clinic to receive important primary and preventive, cost-effective management of chronic conditions and life-saving mental health and substance use services. In short, this coverage allows these patients to receive the right care in the right place at the right time. As Senator Bradley noted, this program has helped to reduce the number of uninsured patients seeking care at hospital emergency rooms. Since the inception of the program, hospitals statewide have seen a 63% reduction in the number of uninsured patients seeking care in the emergency department, a 58% reduction in the number of uninsured inpatient admissions, and a 49% reduction in the number of uninsured outpatient visits. This has resulted in a significant drop in the amount of uncompensated care attributable to those without insurance. In state fiscal year 2014, the first year of New Hampshire's Medicaid expansion program, hospitals reported $173 million in uncompensated care costs attributable to those without insurance. As a result of Medicaid expansion, those uncompensated care costs have dropped dramatically to $69 million in state fiscal year 2021, a direct reflection of the additional health insurance covered provided by the Granite Advantage Healthcare Program. Continuation of this vital program is an important investment in the health of our state and the people it serves, and we urge its continued reauthorization. We appreciate the bipartisan support that the Granite Advantage Healthcare Program has received over the years, and we offer our strong support of Senate Bill 263. Again, thank you for the opportunity to share our views. I'd like to ask John Skevington to make a few remarks, and then we'd be happy to answer questions.
Sure.
Good afternoon. As noted, my name is John Skevington. I'm the CEO of Parkland Medical Center in Derry, New Hampshire. I'm also, Parkland Medical Center is affiliated with HCA New Hampshire, which also includes Portsmouth Regional and Frisbee Memorial Hospitals. In 2022, together, our 3 hospitals and 2,600 staff members delivered health care to residents throughout the Granite State in over 500,000 patient encounters. With the benefits provided by Granite Advantage, our uncompensated care for our 3 hospitals, which totaled over $14 million, was able to be decreased by 8% from the prior year, in large part due to Granite Advantage. Why is this important to us? Over the last 3 years, hospitals have weathered tremendous challenges, and we continue to see uncertainties and rising costs around workforce, supply chain, and capital costs. Reauthorizing Granite Advantage would help create some certainty in a very uncertain climate for health systems. Reauthorization is not just important for hospitals, but also for the communities we serve. There are businesses and providers in our communities who rely on Granite Advantage to continue to serve patients and provide preventative care for those patients. Your support of this important program will help many of your constituents in your community hospitals. And in conclusion, I add my voice with the New Hampshire Hospital Association in support of Medicaid expansion reauthorization. Thank you.
Thank you. Questions? Representative Shapiro.
Thank you, Mr. Chairman. Thank you for taking this question. I've read that the New Hampshire Fiscal Policy Institute has estimated that $3.23 billion has come into the state through Medicaid expansion during the whole time of Medicaid expansion. So that's a lot of money, and for both unreimbursed care, what would have been unreimbursed care, and other kind of cascades down the line. When we talk about tax policy, there's always a lot of emphasis on how important it is for businesses to know what the policy is going to be going out years and years because of the need to plan. And I know that right now there's a debate about whether this should be permanent, as this bill says, or whether it should be 2 years or something in between. So my question is really, how important is passing Medicaid expansion that is permanent or long-term in terms of fiscal planning for medical institutions?
I'll start. I would say it's very important that we have that level of stability so that we understand what that will look like. It's important for hospitals, but also think about the small independent provider, the small practice, someone providing behavioral health services, seeing patients who are covered by Medicaid expansion, not knowing whether those patients would continue to be covered through insurance would be a really challenging thing for them to plan to whether they could continue to serve those patients. There are other issues of importance for the health plans to be able to understand that that's going to be a longer term contract. I know that there will be others who will speak to that issue. But again, we think that's an important piece. And as Senator Bradley noted, the program has certainly stood the test of time. And as we all know, any legislator can introduce a bill at any point in time to make a change to a program. So we believe removing that sunset provision is an appropriate thing with the level of oversight that will continue. I don't know if you have
No, I think Steve answered that very eloquently. I have nothing further to add.
Thank you. Other questions? Seeing no other questions? Okay, thank you.
Thank you.
Also signed up to speak is Henry Lippman from the Department of Health and Human Services. And again, sir, you have 3 minutes.
For the record, Henry Lippman, State's Medicaid Director. I'd like to make 3 points, so I make sure I stay within the 3 minutes. The term of reauthorization is important in terms of getting value for the procurement. We're currently due to reprocure the contract during 24 fiscal year, and I think it's important to have a term that allows MCOs who may be bidding for the contract to have a reasonable expectation that their upfront investments in building compliance with the contract, that they'll get a return on that. And so I think that's one point. The second point I'd like to make is sort of to tie to what Senator Bradley was saying earlier, that Medicaid expansion as a program is not just good for within the Medicaid program, but it's been very good for the insurance markets in New Hampshire, as Senator talked about. What effectively Medicaid expansion does for our insurance markets is a population that has maybe a different utilization level than other parts of the market, is out of the other risk basis, which allows better pricing. And I think where we're number one in the country in the number of people covered by employee-sponsored insurance, and we have the lowest benchmark premium on the exchange. And I think you have to look at this as part of, I think, a policy tool, not only to help people that are on Medicaid, but it's helping everyone in the state. And finally, on the matter of quality and workforce, we've actually seen during the period of before the federal public health emergency today, Senator Bradley talked about 70% of the Medicaid population working. That's higher than pre-pandemic levels. And lastly, in terms of quality, we do track a lot of metrics, about 300 on the program all told, and we have a website if you'd like to look at that. But I would mention a couple things that generally in Medicaid, there are areas where we even outperform the commercial market in terms of the care management that's with the program. Just one example is control of diabetes in the common H1AC dimension, that the rates for New Hampshire Medicaid are higher than in other parts of the market. And also in terms of the important services of follow-up after an emergency room for either mental health and SUD condition, higher than in the New Hampshire commercial market. With that, I'll stop and take any questions.
Thank you very much. Questions? Oh, yes, Representative Murphy.
Thank you, Mr. Chairman. Thank you for taking my question. My question is, I believe that you have, if I'm not mistaken, 3 MCO contracts in the Medicaid program. Is that correct?
That is correct.
And how long does each contract usually negotiate for?
Yeah, in the program, it's been 5-year terms.
And how challenging would it be to go to 2 years, or how beneficial, as it conversely stated, would it be to allow this to be a permanent change?
at House Division 3, I testified, the concern I have was with a 2-year reauthorization that was talked about there is that it would actually only amount to 1 year under the procurement.
Thank you.
Other questions? Representative Weber.
Thank you, Mr. Chairman. Thank you for taking my question. I was scribbling as fast as I could, but I missed your point number 3, which was about the workforce, and then I missed the last part of that.
So in terms of workforce, the 70% number that Senator Bradley referenced, that was in the Kaiser report. If you go back and look at 2019 report, that actually the number of people that are working in the Medicaid, within Medicaid, is higher today than it was before the pandemic.
Okay, thank you very much.
And the second point was regarding the quality indicators in terms of diabetes care. Okay. Very good.
Workforce issue.
Representative Merchant.
Thank you, Mr. Chair. And thank you for taking the question, Ms. Lippin. Earlier on, I asked the question to Senator Bradley. My concern is that for the last 2 years, there's been sort of an emergency federal order to protect Medicaid people from income issues, and it could be taken off Medicaid because of that. However, that's been changed, and we'll think it's May 11th. Over the next 9 months, the department's going to go through that reevaluation process. My concern is what impact it's going to have on those individuals that may not qualify, and then what can the department do to try to help them apply for individual coverage or supplement them. I'm just concerned for like 25, 30,000 people that may not qualify. What can we do about that?
So we've been doing a lot, and just in the interest of time here, I think let me just highlight a few of the sort of the key ones. Is that an individual that's over income that completes their redetermination, we automatically refer them to the federal exchange so that they can be picked up on. We went further than that. We were the first state in the country to approach CCIO, which is the agency within the federal HHS, to be able to actually, people who in the past would do nothing about that their application would just sort of be like a dead letter, wouldn't go anywhere. And so now we have a mechanism to communicate back so that those individuals can be picked up and offered the opportunity. There's a special enrollment period available to people who lose their Medicaid. They have between between April 1st and July of 24. And so we've been working extensively with the state's navigators through the New Hampshire Insurance Department. We've been working extensively with the MCOs, and we've given them their patients list so that they can do outreach. We've worked with community mental health centers, FQHCs, and giving them their patient list to let them know in detail what individuals they're caring for that have a redetermination that's outstanding. Quick statistics. We never stop, like some states, processing applications or asking people voluntarily to complete their redetermination. We had about 103,000 people at the end of March that were protected by the continuous enrollment. We'd actually were concerned about how many people would be affected. So we worked for a couple of years to get people to do it voluntarily. We got over 32,000 people to complete their redetermination on a voluntary basis, thereby reducing the workload so that we can give people the attention they deserve. And then secondly, people have let us know over, I think 3,300 people now, maybe 3,500 have let us know that they no longer need Medicaid because they have, based on our outreach. We're doing all we can. I think we've come at this. We don't want anybody to lose coverage that qualifies, and those that can't, we're trying to help them find other options.
Thank you. I just want a quick comment. I want to say much appreciate your involvement in what you're doing, the department as well, going, my opinion, above and beyond what's probably required. I think it's the humanistic side of the department that I see, which is thank you.
Thank you.
Other questions? Yes, Representative Cushman.
Thank you, Mr. Chairman, and thank you for taking my question. So thinking about the MCO contracts, and I'm sure that they're, in addition to, the funds that come from the state and federal government to pay for the actual care, there's probably a baseline compensation for the MCOs for the administrative costs Do you know what those are per enrollee per day?
I don't have it on a per day basis. I can give you on a percentage basis and roughly what came out in dollars in the most recent contract. But basically, when I was in front of Governor and Council, one of the key things that I'm always facing when I come to Governor and Council is, the challenge of how much we're paying for administration. We're currently paying among the lowest, I think, in the country with respect to the administrative costs. We're paying between for the administrative component, depending on the eligibility class, between 7.4 and 8.3% of the capitation rate. There's built in on top of that, we spend about 90% of the dollars are on medical care. 2% is for the premium tax, and 1.5% is the built-in actuarial margin into the program. And it's very lean, and I think that we've spent with the enrollment in this current amendment that we're operating under, we're about 250,000 individuals today in total in the program, not just expansion, but the entire program. It was about $105 million in administrative costs.
Thank you.
Out of a 1.3 billion plus contract.
Other questions? Seeing no other questions? Okay, thank you.
Thank you.
Also signed up to speak is Senator Cindy Rosenwald from Nashua. And Senator, you put down 5 minutes. If you could keep it to 3, I'd appreciate it. Okay, thank you.
Yeah, thank you, Mr. Chairman, members of the committee. For the record, I'm Cindy Rosenwald from Senate District 13. I'm here to speak in strong support of Senate Bill 263. This program not only benefits the health of tens of thousands of New Hampshire residents. It's also a very significant pro-business program because a healthy working age population is an employable population. Since its inception in 2014, Medicaid expansion has been a lifeline for hospitals, particularly the small rural ones, reducing uncompensated care. As Senator Bradley said, uncompensated care leads to higher premiums for people who have private insurance. And because the federal government funds almost all of it, Medicaid expansion is a significant economic driver. Last year alone, it represented a $500 million investment in our state's economy. The program has several built-in safeguards for taxpayers. Senator Bradley spoke of removing a prospective repeal as making the program permanent. Strictly speaking, that's not the case. As the U.S. Supreme Court issued an opinion more than 10 years ago now, as a waiver program, it is completely voluntary. While no state has stopped Medicaid expansion, all of them could. And New Hampshire could stop Medicaid expansion by notifying CMS that we wanted to, winding down the waiver. It would probably take 6 or 9 months, but there's not really permanency in it because it's a voluntary program and it's a waiver program. I've been honored to work with Senator Bradley on this program since its inception in 2014. Actually, we started working on it probably in 2012. Granted Advantage is an extremely successful program, and I think we need to reauthorize it. Thank you. I'm happy to take questions.
Thank you, Senator. Questions? Representative Cushman.
Thank you, Mr. Chairman. Thank you for being here, Senator. I want to know your opinion. What do you make of the recent statement, the recommendations released by the Congressional Budget Office that due to the federal deficit and the immense amount of debt that we're dealing with federally, that they recommend that the states and the federal government decrease Medicaid enrollment and increase the state portion of funding for Medicaid? And how does that impact the future of this legislation?
Well, in terms of this program, the 90% federal contribution is not by regulation, it is in federal statute. It can only be changed by an act of Congress. And let me just say that the federal government has never, ever not made good on its promises for paying their percentage of Medicaid costs. In fact, several times since I've been in the legislature over the past 9.5 terms, the federal government has increased its proportion of matching funds, either for children for the last few years, for all of Medicaid except for Medicaid expansion. So I really don't see any change in the federal matching percentage for this program.
Follow up.
Thank you. Well, I'm concerned, what do you make of the effect that this will have on national debt and inflation? Because the federal government is picking up more of the tab, and with the increase in spending, we're printing more money. We have a higher deficit now than we ever have. You know, nationwide, this is an issue, and it impacts us here in the Granite State. Do you have any trepidation about that?
Thank you for the question. I'm not an economist, but I think with lots of other changes in the world and in federal law over the last 4 or 5 years, there are many other things that have contributed to federal debt rather than Medicaid expansion in the 40 states that have done it.
Other questions? Seeing no other questions? Oh, I'm sorry, Representative Weber.
Thank you, Mr. Chairman. I just have one for you, and that is this bill going to finance after it finishes with us?
Yes, it is.
Okay, thank you. That's reassuring.
Thank you. Thank you, Senator. Next person signed up to testify is Doug McNutt from the State Commission on Aging. Again, sir, you have 3 minutes.
Microphone.
Yep, put your microphone on, please.
So is it on? Okay.
Yeah, there you go.
For the record, my name is Doug McNutt. I'm a member of the State Commission on Aging. I serve with Representative Weber on that commission. In the past, I've worked for AARP, and I also worked for the Department of Health and Human Services and Division of Elderly and Adult Services. I come here today representing the State Commission on Aging, who is in support of this bill. I've passed out written testimony, and I want to just talk about a couple of things that probably some of the other testifiers won't be mentioning. I'm going to focus on the category of people that are 56 to 64 that are taking advantage of Medicaid expansion. That's a population for whom health insurance is very expensive. There are people who oftentimes have lost jobs, and at that age, it's very difficult to get the next job. This program is a lifesaver for those people in terms of keeping them healthy so that they can continue to work and take on that next job. At this point, the figures from last year indicate about 15% of the people on Medicaid expansion are from that age group. And they are a particularly vulnerable group of people, and this program is critical for them. The other thing I want to mention briefly is that this is also helpful for caregivers in terms of taking care of people who are in that age bracket and significantly older. This helps the workforce situation and the people who are low wage are able to get health insurance when they need it. And it is also helpful in terms of that regard. So those are the two principal things that I wanted to focus on, and I'd be happy to answer any questions you might have.
Thank you. Questions from Mr. McNutt? Seeing none, thank you very much. Also signed up to speak is Greg Moore from Americans for Prosperity. Again, sir, you have 3 minutes.
Thank you, Mr. Chair, members of the committee. I'll make this as brief as possible. There are two issues, as the sponsor said, relative to this bill. One is to the merits of Medicaid expansion, and the second subsidiary issue is what time duration, if there should be an expansion, should it last? Those are the two fundamental issues here. I'll address both. In the first instance, and by the way, this is actually the fifth time we've done Medicaid expansion. There's 2013, 2014, 2016, 2018, and now. And I also want to point one thing out, which is the senator and other speakers have mentioned a drop in health insurance costs. I will say that I monitor this pretty closely, and the correlation to that appears to be with an insurance waiver that the Department of Insurance filed in 2018 relative to setting up a statewide reinsurance pool. And that correlates much more closely with the drop in health insurance costs than the 2014 expansion of Medicaid. But Americans for Prosperity opposes this legislation, and it does so for a couple of reasons. First and foremost, as the sponsor mentioned, there is concern about the impact of a welfare or benefits cliff. We know this is a big issue. It's an issue that's been discussed on both the left and the right, and I know the department issued a report on this very issue last week. Oddly enough, they seem to tackle every means-tested welfare program in the state except for Medicaid, which I find is a little bit of an outlier. But it's not so much whether people work or not work, as the sponsor said. The question is whether people will work further, take a job that pays a little more, seek out more hours. That's really the challenge. Is the benefit cliffs impact that aspect, not whether the binary decision as to whether or not to work. So we think that's an important factor for the committee to consider. The second factor for the committee to consider is the impact of all the induced demand that putting hundreds of millions of dollars of new money into the healthcare marketplace makes. Now, we do know it reduces uncompensated care. There's no question that it reduces uncompensated care, but we're spending $500 million a year on Medicaid expansion, and the reduction in uncompensated care is well less than that. The other money represents an induced demand that is causing more utilization. That utilization has put a strain on our healthcare workforce, and we now have provider shortages across the state. When I worked at the department, provider shortages were something that were fairly rare, sometimes within unique fields, and particularly in the northern parts of the state. Now we see them widespread across the state, and this induced demand does have an impact on that. The second issue relative to the time frame, as to whether or not this should be permanent, or as the House Finance Committee recommended, a more temporary expansion of Medicaid. And what I would say to that is, I do expect there will be federal action. I know this because a former boss of mine that Representative McKay knows well, and Representative McDonald knows well, has been talking with members of Congress, and there is an effort afoot to look for ways to try to bring reforms to it. A lot of those reforms look like some of the reforms that Representative McKay would remember from TANF, which is such as allowing for the provision of work requirement. New Hampshire does have a work requirement law, but it's been disallowed by the federal courts. In other words, changing the federal law to allow work requirements and potentially a lifetime benefit cap similar to what's been in place with TANF. So for those reasons, we think it's important for us to consistently refresh and look back at this program and to determine whether we need to make adaptations, as we did with the TANF program, TANF reauthorization back in 2006. And just as TANF is reauthorized, we should be doing the same with Medicaid expansion as well, because I do expect there will be federal action at some point.
If you could start wrapping up, please.
Absolutely. So with that, I'll leave it there, and I'd be happy to take any questions from the committee.
Okay, thank you. Any questions from Mr. Moore? Representative Shapiro.
Thank you, Mr. Chairman, and thank you for taking the question. You talked about, you seem to be advocating for a shorter term reauthorization because there might be changes coming along and we should be able to be nimble to adjust to those changes.
Representative, we oppose the program in its totality. However, what I was saying is that the House Finance Committee, with the budget that you'll be voting on Thursday, has a shorter duration, a 2-year extension for Medicaid expansion relative to this legislation. I was comparing and contrasting the two approaches.
Follow up. Well, isn't it true that if this is made permanent, if this bill is the bill that predominates and it's made permanent, couldn't changes be made in any case just by introducing new legislation?
That's certainly a prospect, but if you look at this would be the third reauthorization, so 2016, 2018, and now 2023. Every time that there have been that this has been reauthorized, there have been major changes to the program. So it creates a consistent inflection point for the legislature to look to take action. So we think that's a healthy approach.
Thank you.
Other questions? Seeing no other questions, thank you.
Thank you.
Also signed up to speak is former Senator Tom Sherman. Again, sir, you have 3 minutes.
Thank you. For the record, my name is Tom Sherman. I'm a physician in Exeter and former state rep and state senator. And I always feel like I'm coming home when I come back to Health and Human Services and Elderly Affairs. I see my former vice chair and my former chair, and it's just great to be here with you all. First of all, my background on Medicaid expansion is that I was on the original commission that created the bipartisan proposal for Medicaid expansion. That included, as Representative Cushman alluded to, the circuit breakers, that's what we call them, the taxpayer protections that are in the bill currently. And that also anticipated the need to have expiration dates or reauthorization dates. And one of the circuit breakers, just to address Representative Cushman's earlier question, was that the program would automatically go into a reauthorization if the federal component dropped below 90%. So I think that was one of the reassurances that we had and continue to have. Whether or not this is made permanent, that circuit breaker or taxpayer protection will be there. What I wanted to focus on today very quickly is the human side. It's also the fiscal side. When I was practicing before Medicaid expansion, 2 patients really stood out to me. One of them had ulcerative colitis. It was actually very easily treated with an oral medication that he couldn't afford. And as a result of not being able to afford it, he was bouncing in and out of the hospital about every 6 weeks. He lost his job. He lost his home. His family was dependent completely on public assistance. But with Medicaid expansion, having seen the before and after as his provider, not only did he recover his job and his health, but his home. And the interesting part to this is that he went off public assistance, went off Medicaid, and was able to be fully self-sufficient once he got his health back. The second one was more poignant for me. It was a woman who not only lost her job, her home, but also her family. She was homeless. And we took everybody at Core Gastroenterology, and she walked in with multiple medical problems, only one of which was in my specialty. But through Medicaid expansion and getting her that coverage with the full complement of 10 essential services, not only did she recover her health after Medicaid expansion, but she also recovered her home and eventually her family. The point here is that real people, these are Granite Staters, these are our neighbors, our families. These aren't people, as Director Lippman pointed out, 70% are working. These are people who are working. They want to work. They want to be out in the job market. We need them in the job market.
Please start wrapping up.
But the most important point here is that this is the key to getting them back into the workforce and getting them their dignity, their life, and their economic stability back. So I appreciate your vote. I strongly support this. I always have. And you will be saving lives when you pass this. Thank you.
Thank you. You taking questions?
Sure.
Any questions for, yes, Representative Cushman.
Thank you, Mr. Chairman. Thank you for taking my question. It's a simple one. Do you know what the work requirement is exactly? Is there a number of hours per week that is required of the enrollees?
It's my understanding that there is no work requirement currently because the federal courts actually struck down the work requirements in other states. Even though we passed a work requirement, it couldn't be implemented because of federal. That's my understanding. You can check that. I'm sure Director Lippman would know the answer to that.
Other questions? Seeing none, thank you. Oh, I'm sorry. Representative Weber.
So would it be your testimony that we are succeeding in returning people to the workforce despite the fact that the work requirement is not currently being enforced?
Absolutely. And, you know, when you look at the income levels that allow you to qualify for Medicaid expansion, then think about trying to live at that income and also manage your own health care costs. It's daunting. But all of my patients who have come in on Medicaid expansion have gotten the exact same care as commercial carriers. Patients covered by commercial carriers, they have been working. And one other point is that I'm sure you know of the Oregon study that was done through Harvard. That study showed that one of the first benefits is that economic stability that allows people to go back to work. And I think that's really important. We understand the impact of healthcare bills. It breaks people's home budget completely. So having this as a tool, it doesn't keep people off work. It actually gets them back to work and off of public assistance. And that has been my clinical experience in my own practice.
Thank you. And welcome back.
Thank you. It's great to be here.
Other questions? Seeing none. Okay.
Thank you.
Thank you. Also signed up to speak is Peggy Gilmore from the Nashua Chamber of Commerce. Or should I say former Senator Gilmore?
Thank you, Mr. Chairman. It is like Old Home Week.
And you do have 3 minutes, Senator.
Yes, thank you. Thank you, Chairman McDonald and members of the committee. For the record, I'm Peggy Gilmore from Preddy Strategies, but here today representing the Greater Nashua Chamber of Commerce. Wendy Hunt, our president and CEO, had very much hoped to be here to testify because this bill is a #1 priority for the Nashua Chamber of Commerce, but she's winging her way home from Greece as we speak, so that took priority. The Greater Nashua Chamber of Commerce represents over 400 business members. They're large, they're small, they're for-profit, nonprofit, every sector, manufacturing, hospitality, healthcare. And this is a very important business-related bill. You'll hear a lot about the health improvements that have come through Medicaid expansion. I'm here just to talk about why it's so important to the businesses. And we know that we've heard over and over again that we're lacking in many instances a work-ready workforce, a healthy workforce ready. Lack of insurance is the biggest deterrent to both preventative and necessary, particularly for chronic health conditions, health care. Greater Nashua has 2 major hospital systems. We have home care, mental health providers, substance abuse providers. All of these are major employers in the Greater Nashua area. Without Medicaid expansion, these employers lose significant funding, and the members of those that are uninsured, as you've heard, repeatedly, will rise dramatically. And you've heard that the data on uncompensated care costs will rise, and those costs are then passed on to the private insurance contracts, and then to the employer who offers health insurance, and then to the employee in the form of higher premiums that they get from their work environment. Senator Bradley has referred to this as a hidden tax, and he's absolutely correct. This is exactly what this is. Cost shifting is a hidden tax. And finally, again, as you've heard and will hear repeatedly, Senate Bill 263 calls for permanent reauthorization. We know that what our businesses want and ask consistently from our government is stability and predictability. To limit authorization to 2 years or 4 years or 6 years threatens that predictability. So on behalf of the strong business community of the state's second largest city and all of its surrounds, we ask that you find Senate Bill 263 permanently authorizing Medicaid expansion ought to pass. And you could follow the Senate's way and do it unanimously. So I thank you for your time and for your attention to this important bill, and we'll take any questions that you may have.
Thank you. Questions for Senator Gilmore? Seeing none? Okay, thank you. Also signed up to speak is Sam Hawkins from NAMI, New Hampshire.
Thank you, Chairman and committee members, for the opportunity to testify today.
You get 3 minutes, sir.
Yeah. My name is Sam Hawkins. I'm the Public Policy Assistant at NAMI New Hampshire, the National Alliance on Mental Illness. NAMI New Hampshire is a nonprofit grassroots organization whose mission is to improve the lives of all people impacted by mental illness and suicide through support, education, and advocacy. On behalf of NAMI, I'm here today to speak in strong support of Senate Bill 263. Alongside my written testimony, I've passed along written testimony from a constituent who really wanted to be here, but unfortunately was unable. Of all the challenges facing Granite Staters, our mental health crisis is paramount. In New Hampshire, 221,000 adults have a mental health condition, and 15,000 minors ages 12 to 17 have depression. Despite the availability of effective treatment, over half the individuals living with a mental health condition in the U.S. do not receive treatment. Like other medical illnesses, delays in treatment mean progression of the seriousness of the illness and more difficulty and cost when the person does eventually receive treatment. For those living with a mental illness, these delays can result in outstanding personal and productive losses that harm their livelihoods and could be life-threatening. In 2021, of the adults in New Hampshire who did not receive mental health care, nearly 42% did not because of cost. Increasing access to care is crucial in addressing New Hampshire's mental health crisis and reducing the human and financial cost of untreated mental illness on our state. NAMI New Hampshire applauds the current success of the New Hampshire Granted Advantage healthcare program and the efforts to reauthorize it in perpetuity. The positive impact this program has in improving access to care is obvious. In 2021, through the Medicaid expansion program, over 11,000 unique individuals received mental health outpatient services, nearly 830 accessed inpatient psychiatric hospitalization, and over 26,500 obtained mental health medication. Regarding our rising rates of youth mental illness, research shows that more children are covered by insurance in states with Medicaid expansion than in those without. This program also goes a long way in addressing our state's substance use crisis, as more than 7,000 individuals in the program sought substance use disorder outpatient services, 7,500 engaged with medication-assisted treatment, and 2,300 obtained inpatient or residential SUD treatment. SB 263, which reauthorizes the crucial and successful New Hampshire Granted Advantage healthcare program, is one of the most impactful measures the legislature can employ in supporting Granite Staters. For these reasons, NAMI strongly encourages the committee to vote ought to pass. If I can take any questions.
Thank you. Questions? Any questions from committee members? Seeing none, thank you.
Thank you very much.
Also signed up to speak is Chris McCracken from Amaskeg Health. Good afternoon.
Good afternoon.
Again,
I hope you won't hear my stomach growling.
we won't listen to your stomach growl if you don't listen to ours.
Fair.
That's
And Mr. Chairman and members of the committee, my name is Chris McCracken, and I serve as the CEO at Amaskeg Health. And I think we are maybe the largest federally qualified health center in the state, located in Manchester, New Hampshire. And so I'm kind of presenting this from the perspective of a patient care provider, and a care provider that is focused on a population of people who have limited income and resources to provide themselves access to care. At our organization, 43% of our patients do not speak English as their primary language. We serve the largest number of beneficiaries of the Granite State Advantage Healthcare Program of all of the FQHC's, federally qualified health centers in New Hampshire. Over 50% of our patients are insured through this program. In the last 5 years, we've seen a 12% increase in patients and a 116% increase in the number of patients seeking SUD services. And we know that the members of our community and communities that you represent have better access to healthcare services that they desperately need when they have insurance. And I'd like to demonstrate that through a patient care story. I always think that's the most impactful way to think about a program such as this. This is a story that our Associate Medical Director of Family Practice shared with our team, and I thought it was really poignant, and I thought it would make sense to share with you. She had a patient that was in his mid-50s that she had been providing health care for over 15 years. Construction worker, great guy, but suffered with diabetes and sugars constantly out of control, couldn't do anything to kind of get them established. And after the implementation of the Granite State Advantage and Medicaid expansion in New Hampshire, suddenly his numbers started to come down. And she said, all right, I got to ask, I don't know what we did differently this time, but suddenly it's working. And he said, because I can afford my medication. I can afford my test strips. I'm testing regularly. I'm taking the medication as you prescribe it. I'm not cutting my doses. Suddenly, he's doing it excellently. His sugar is controlled. And this has really enabled him that ability to stabilize his health and stay out of the hospital and not lose a limb, not lose his eyesight. So you can see that impact for managing chronic disease, and so many individuals face that, and the older we get, the more of those we face. I'll include myself in that group. It's a really critical mechanism, and she often says, if it weren't for Medicaid expansion, so many of my patients, I would not be able to help them effectively manage their care, because when I come to the doctor, I'm probably going to need a test, or I'm probably going to need a medicine, and how am I going to be able to afford that if I don't have a mechanism? And people make horrible, horrible choices about, can I afford my rent, or can I pay my gas, or can I buy this medicine that I so desperately need?
You could start wrapping up, please.
That was really the point of what I wanted to say, so I will stop there.
Okay, thank you.
If you have any questions, I'm happy to try and answer them.
Sure. Questions from committee members? Seeing none? Okay, thank you.
Thank you.
Also signed up to speak is Lisa Britt Solsky Stevens for ES New Hampshire, Vermont, Farnham.
Easter Seal.
Easter Seals, I'm sorry. Well. Good to see you again.
Thank you. It's nice to be seen. Good afternoon.
Again, you have 3 minutes.
Yes. For the record, I'm Lisa Britt Solsky Stevens. I'm the Chief of Government Relations and Compliance for Easter Seals, New Hampshire, Vermont, and Farnham. Today, I want to talk to you about Farnham in particular. It's one of 14 programs and services that Easter Seals manages. Just a note about Easter Seals in New Hampshire. We're in the top 5 largest affiliates of Easter Seals in the country. We touch about 20,000 individuals across the Granite and Green Mountain states. And we're the 12th largest employer in New Hampshire. So Farnham, as you may know, is a CARF accredited substance misuse treatment facility in Manchester. We do inpatient and outpatient treatment at 2 locations. Our Queen City Ave location is a 24/7 residential treatment facility. And Farnham has been doing substance use treatment for over 35 years. Farnham services are evidence-based, which is something critical in this field. Our staff just completed training at Hazelton Betty Ford Foundation so that they can do co-occurring treatment. It's estimated that 80% of people in substance misuse treatment also have mental illness. This will position Farnham well to be able to manage the whole person instead of bisecting between mental illness and substance misuse. I see Representative McKay nodding knowingly. Just this last weekend, our payer mix in detox was 78% Medicaid, and in residential treatment, it was 89% Medicaid. And this is typical at Farnham. Our next largest payer is the Bureau of Drug and Alcohol Services, with whom we have a contract, and it reimburses less than Medicaid does. Asking why Farnham serves so many people on Medicaid is akin to asking what came first, the chicken or the egg. Focusing on the Medicaid population allows us to subspecialize on the social determinants of health that underpin Medicaid eligibility. This is a space that we proudly operate in. The overwhelming majority of our patients benefit from the Granted Advantage program. So recall 87 and 89% of our census was Medicaid. The majority of those are Granted Advantage. And one need not be the chair of House Finance to understand that if the Granted Advantage goes away, Farnham becomes extremely precarious. Permanent reauthorization as contemplated in this bill is needed for safety net providers like Farnham who do not have the ability to do robust cross-subsidization across payers. Our ability to plan for the future for sustainability requires that we know that our primary source of funding is intact. In the absence of Farnham, who will welcome 3,000 or more low-income individuals for treatment for which they cannot pay each year? We all know that those folks will go without necessary care. They will miss the opportunity to get back on their feet, return to family, and work stronger and healthier. National estimates are that 110,000 individuals died last year of overdoses. This does not include deaths due to cumulative impacts of addiction, which are what my father succumbed to last summer at age 70, and my sister-in-law succumbed to last November at age 55.
You could please stop wrapping up.
My sister-in-law lived in Florida while she was fighting cancer. They don't have the Medicaid expansion. She sold her home before going to hospice in order to pay the Mayo Clinic. New Hampshire needs Farnham. Farnham needs the reauthorization. It saves lives. Thank you. Happy to take any questions.
Thank you. Any questions? Seeing no questions, okay? Thank you.
Thank you.
Also signed up to speak is Regina Pike from Rochester. Good afternoon.
Good afternoon.
You have 3 minutes.
Okay, thank you. I'm a little nervous, but
Sure.
I can do it. So, good afternoon. My name is Regina Pike from Rochester, but everybody calls me Gina. I'm here on behalf of myself and many others who are on the Granted Advantage Health Plan. Before divorce, I never heard of the plan. Post-divorce, I lost my insurance and had to choose between getting medical care that I needed or accruing medical debt, since I was a caretaker still to my parents. I applied for assistance, and the Granted Advantage was the only program that I could qualify for, due to my age / not being labeled disabled through SSI. With the Granted Advantage program, I don't have to choose between care / debt. I get to choose my health recovery over being on the couch, not knowing what my illnesses are. Without the Granted Advantage program being available to me, I wouldn't be here right now standing up for myself and many others that are affected by this proposal to make it permanent. I wouldn't be able to afford the treatment for my invisible disabilities, including mental health issues, brain injury challenges, and my other medical conditions. I wouldn't have to be able to, I wouldn't have been able to go to Boston for treatments and then get reimbursed for mileage that Medicaid does right now. I get vision treatment post-concussion, getting out of an abusive relationship with therapy helping, finding my diagnosis of PTSD, depression, anxiety, ADHD, and to be able to go to work at my own pace as a member of the Seacoast Pathways, a clubhouse. They are a mental health nonprofit that helps people get back to work. With my conditions, I can't focus on getting healthier as well as getting back to work at the same time. So taking care of my health because of the Grin Advantage program has helped me be able to work part-time. I DoorDash because my parents recently passed away. So this helps me get back to work and to be able to have the services I need and the support for me to have a healthier life for the rest of my life because I'm only 39. So I propose that you say yes to keeping this program and to keep it permanent so I don't have to have the anxiety of just waiting for it to end or to I read determination all the time and I get anxiety from that. So I don't need the anxiety of having that plus waiting to see if this is over, you know, like with our notices that we got, it was anxiety provoking. So if you have any questions, I can answer.
Thank you. Any questions? Seeing no questions. Okay, thank you very much.
Thank you.
Also signed up to speak is Peter Mason from the Medical Society and Headrest.
Mr. Chairman and hungry members of the committee. My name is Peter Mason. I'm here representing the Medical Society and Headrest. I'm a family physician, and I've practiced in Lebanon for over 40 years. Since 2005, I've worked extensively with individuals struggling with substance use disorders, and I'm currently the medical director of Headrest, an outpatient and transitional living facility for people in recovery with offices in Lebanon and a sober living house in Boscawen. Approximately 90% of the individuals I care for are covered by Medicaid. When Medicaid expansion became effective in 2014, it enabled them to have access to treatment for their substance use disorders as well as for other chronic physical and emotional illnesses. Suddenly, they were able to establish with PCPs and get preventative and continuity care rather than presenting to emergency rooms in crisis when their problems were more advanced, leading to more expensive, inefficient, and episodic care. As a result, Medicaid expansion has decreased the burden of illness and it's saved countless dollars. As bad as the healthcare system is today, it's hard to imagine how much worse things would be without Medicaid expansion. I've delivered hundreds of babies, but equally rewarding is the work I do with people in recovery. To see them stabilize, get their lives back together, engage in productive work, reunite with the loved ones, and stay out of trouble is incredibly gratifying. Many of these individuals have a history of incarceration. Now they're productive, tax-paying members of society. We need to make Medicaid expansion permanent. Without the clarity of funding that permanent reauthorization provides, not only the agency I work for, but also so many other health and social service providers would not be able to continue their work. And most importantly, the people we're serving will lose the care that they so desperately need. Please support this legislation, and I'm happy to take any questions.
Thank you. Any questions? Seeing no questions? Okay, thank you. Also signed up to speak is Bob Dunn from Londonderry, representing the Roman Catholic Bishop of Manchester. And since Londonderry is the community I'm privileged to represent, always happy to see somebody from Londonderry. So.
Thank you, Mr. Chair. Thank you for your service on behalf of the town of Londonderry. Good afternoon. I'm Bob Dunn, the Director of Public Policy for the Roman Catholic Diocese of Manchester, and I'm here today on behalf of Bishop Peter Labashi and also on behalf of Catholic Medical Center and New Hampshire Catholic Charities to register our support for Senate Bill 263. I have just two quick comments to make. First, a bill like this is important for a number of reasons, and one of them is that it once again reemphasizes the fundamental place of the principle of the common good. And you've heard me say in front of this committee before that it's important for us to remember that the principle of the common good is not just a religious sentiment, but it is at the heart of the constitutional order that was left us by the framers of the Constitution. Part 1, Article 1 of the New Hampshire Constitution says that that government was instituted for the general good. Second, it's clear from what you've heard and what you will hear that the Granite Advantage program has improved the lives of tens and tens and tens of thousands of New Hampshire citizens. And there are many people, obviously, who are alive today because of the health care that they received under Granite Advantage. That seems obvious. And so manifestly, in our view, Senate Bill 263 is a bill that can and should be seen as a pro-life measure. Now, the Medicaid program may not be perfect, but we think that this bill boils down to just one question. What would be the mechanism for providing health care to the Granite Advantage population if Granite Advantage were to disappear? And since we all know what the answer to that question is, we think that we think that Senate Bill 263 is a good idea, and we ask you to vote ought to pass. Thank you.
Thank you. Any questions? Yes, Representative King.
Thank you, Mr. Chairman, and thank you for taking my question. Through the whole Medicaid process that we've gone through this session, I've been asking the question, where the churches fit in helping out with some of our societal issues that we have.
Well, from the Catholic Church's perspective, the church and the state have an obligation to work together to serve the common good. And in fact, we believe that the Catholic Church in New Hampshire, through its diocese and through its parishes and institutions, is second only to the state of New Hampshire as a provider of charitable care. So it's, I think, something where both sides need to do their work. I think the churches are doing the work, and this is where the state gets to stand up and do the same.
Thank you.
Other questions? Seeing no other questions, thank you.
Thank you.
Also signed up to speak is Suzanne Tansky, representing herself and Dartmouth Health.
Good afternoon.
Good afternoon.
Thank you guys for being here and sticking through this tummy grumbling as well. Chairman McDonald and members of the committee, thank you very much for the opportunity to speak in strong support of SB 263, which will permanently extend the New Hampshire Granite Advantage Healthcare Program. My name is Dr. Suzanne Tansky. I'm a practicing pediatrician at Dartmouth Health Children's, and I'm the section chief and vice chair of general pediatrics and a professor at the medical school. I'm speaking today on behalf of myself, on behalf of Dartmouth Health, and that of many of my physician and pediatrician colleagues. I too am going to put a little personal face on this. Most of my patients are younger, and so they don't qualify for Medicaid Advantage, but my parents of my kids do. And I'd like to speak with one example. I've taken care of many parents who have met healthcare needs. And for many years, that's been the case. But I'm going to talk about a success story. I'll talk about Julie. That's not her real name. But I've known Julie for about 7 years as the pediatrician for her kids. And about a year ago, we had her come in for her daughter's 6-month well child check. We screen all of our moms at 6 months for maternal depression, and she scored incredibly high and in depression. And in talking with her, she said, I don't know how I can pay for this. And then she said, wait a minute, I just got healthcare insurance through Medicaid Advantage. We were able to get her the help that she needed. She was already employed. She works at a grocery store. And by getting her this incredibly important mental health help, we were able to keep her at work, keep her being a better mom to her kids, support her family, and have a better household and better society for herself and everyone else. So there are very personal stories of success for this program. This impacts our kids, our families, our society, and everyone throughout New Hampshire. And I applaud you for taking this up and for continuing this program and making this permanent. I'd be happy to take questions.
Thank you. Any questions? Seeing no questions? Okay, thank
Short
you.
and sweet. Thank you, guys.
Also signed up to speak is Dr. Larry Kane.
Good afternoon, and thank you for the privilege of speaking to you.
Sure.
I have a very short statement. I'm a retired physician. I live in Newmarket, and I serve on the board of Southeastern New Hampshire Services. Those services are drug and alcohol treatment services. So my comments will be an echo of what you've heard a bit. My point of reference is saving lives. It goes with my practice. And Southeastern does that. It's in Dover. The services it provides are outpatient and inpatient treatment of substance use disorders. It's been there doing that for 40 years. I've served on the board for 23. I do that because this is a valid, effective organization struggling to help people who are struggling to get out of addiction and into recovery. It's hard work. The reimbursement of our staff is really inadequate. And with inflation and competing salaries elsewhere, that's a real problem for us. 90% of our clients are Medicaid. 50% of our annual revenue is Medicaid. And as you know, we're dealing with a massive problem. Last year we had 434 confirmed overdose deaths. And a few years ago, when they measured, someone's already said this, 100,000 nationally overdose deaths. So the work being done there is critical. And the support we get from Medicaid or BDAS is also critical. So I'm here to support this legislation, anything that would enhance, expand Medicaid coverage, and ideally make it permanent. We simply can't sustain our operations without this support. So I urge you to pass this legislation, and I thank you, and I thank you all for all of the work you do for all of us, all of the time.
Thank you.
You're welcome.
You taking questions? Do we have any questions? Or seeing none? Okay, thank you.
Thank you.
Also signed up to speak is Susan Stearns from Sanberton.
Good afternoon, Chairman McDonald and members of the committee. For the record, my name is Susan Stearns, and I'm a resident of Samberton. I'm here today in support of Senate Bill 263. In the interest of full disclosure, I am employed as the Executive Director of NAMI New Hampshire. However, I do not come before you today in that role. I come before you in what I consider to be my most important role, that of a mother. My child was first diagnosed with an emotional disorder at age 5, a serious one at age 8, and a serious mental illness at age 14. Raising my child was not an easy task. However, we were lucky. My employer offered health insurance that covered my child, and he was able to access the mental health treatment that kept him at home, in his school, and not in an emergency department or residential placement. As my child grew up, there were many sobering realizations for me as a mother, that his path would often be different from that of other children because of his disability, that not everyone in the world would be as patient with him and his approach to life, and that he might not be able to work 40 hours a week for all of his adult life, and that he might not have access to treatment. That last one terrified me. My child had been a treatment success story. Despite some difficult times, he never required a visit to an emergency department or a hospitalization. But without treatment, which he would lose access to without insurance, I knew too well what his path would likely be. He would decompensate, probably become unable to function, be at risk of hospitalization or even homelessness. Once that happened, after what would likely be a several-year period, he would probably be determined to be disabled, and therefore eligible for traditional Medicaid because his mental illness would have proven so disabling. 1 in 5 adults and 1 in 6 children in our state has a mental health disorder, and I am certainly not the only mother to lose sleep many nights fearing for her child's future access to health care. As my child approached his 26th birthday, he and I sat down to apply for Medicaid expansion coverage for him. A few weeks later, his enrollment letter arrived, and I read it and wept. Since first becoming eligible for Medicaid expansion, my child has had periods where he has been able to work and has had his health insurance provided by an employer or been able to purchase it himself on the marketplace. When times have been more challenging, he has been able to access the mental health treatment necessary for him to live a full life through Medicaid expansion. So to all the legislators who enacted Medicaid expansion in our state, and those who are working to move it forward with this legislation to reauthorize it, thank you. Words cannot express the gratitude that this mother has for the safety net that Medicaid expansion has provided to my child, and I know I am only one of many parents to feel this way. So thank you for helping us all sleep a little better at night knowing our children have access to essential health care.
Thank you. Any questions? Seeing none, thank you. Also signed up to speak is Christina Fitzpatrick from AARP.
Hello, my name is Christina. I am Christina Fitzpatrick. I am the State Director for AARP New Hampshire, and I am here today to speak in support of SB 263. AARP has 210,000 members in New Hampshire, and what I would like to do is explain to you today why SB 263 and the permanent reauthorization of the program is important for our constituents, people 50 and older, and specifically people 50 to 64, because people older than that most likely qualify for Medicare. So people age 50 to 64 were probably not eligible for health insurance through Medicaid prior to the development of the Granted Advantage Healthcare Program, because the Medicaid was only available to people with children, people with a disability, and some people with ages 65 and older. Now with the Medicaid expansion, the Granted Advantage Healthcare Program, they are. If they qualified with their low income. They may have a job with no health insurance. They may have lost a job and have trouble getting a new one. And that is more likely when an older worker loses their job, it's much more difficult for them to become reemployed and to become reemployed in a job offering comparable pay and benefits. Insurance is especially important for people 50 and older because we know that people without access to health insurance delay care, which can lead to late diagnosis, poorer outcomes, more expensive treatment. And that's especially true for older people because they are more likely to have healthcare needs, more likely to have chronic health conditions that need to be managed. And the lack of health insurance can make it harder for them to stay in the workforce. You have heard from others about how this is important for how extending this program is important because when people have access to health insurance, they are healthier. They are less likely to seek uncompensated care in hospitals. That leads to savings in the state budgets, means lower premiums for employers and for people with private health insurance. We get all of this with the federal government absorbing 90% of the costs. And this program brings in $500 million a year to the state of New Hampshire, which helps to improve our economy in addition to helping people maintain their health. We know that the Granted Advantage Healthcare Program has created sizable positive effects in New Hampshire. It's time to make the program permanent. I urge you to vote in favor of Senate Bill 263.
Thank you. Any questions? Seeing no questions, thank you. Also signed up to speak is Lisa Madden for the New Hampshire Community Behavioral Health Association. Periodically, I do need to remind everyone, and you're all doing a great job, by the way. We do have a 3-minute time limit, but everybody's being great, so.
Promise to stick to it. Hello, everyone. My name is Lisa Madden. I'm the president and CEO of Riverbend Community Mental Health Center in Concord. I also serve as the vice president of behavioral health for Concord Hospital. I'm here today representing the New Hampshire Community Behavioral Health Association, which is comprised of all 10 of the state's nonprofit community mental health centers, all of whom strongly support permanent authorization of Medicaid expansion in 2023. Thank you for giving me the opportunity to speak to you today. There is no doubt that the benefits of Granted Advantage Healthcare Program for New Hampshire residents who need mental health care and substance abuse and addiction treatment services are significant. Data from the Division of Medicaid Services show that in 2022, over 11,000 individuals enrolled in the program received mental health outpatient treatment. Almost 30,000 used mental health medication treatment, and almost 9,000 received substance use disorder outpatient services. In collaboration with several state departments, ease of access to mental health care and substance use disorder services has greatly improved. The Rapid Response Access Point simplifies the way one can access mental health services. The Doorway is a network of providers that simplifies the way one can access opioid and other substance use disorder treatment. Improving access is a critical step, but having access to healthcare insurance through Medicaid expansion allows people to continue to participate in the treatment over the long term. Please allow me to share a couple of examples. Joe lives in Laconia. He was previously uninsured, homeless, living in a shelter, and not engaged in treatment. Thanks to the Granted Advantage program, he became a patient of the local community mental health center in April of 21. With the help of the CMHC staff, Joe was able to enroll in the Bridge program. He began receiving case management services through that program. He has remained positive throughout his recovery, and now 3 years later, has his own apartment. He's employed and actively focusing on his budgeting skills so he can be more independent. Bob is a young man referred to the Concord Doorway from the Concord Hospital Emergency Department in the spring of 22. During his assessment, he identified many barriers to staying engaged in treatment. He was uninsured, unhoused, unemployed, and had a history of serious mental illness, including considerable self-harm behaviors. Bob eagerly completed the application for Medicaid with the assistance of the Doorway staff. The new parameters for expanded Medicaid allow Bob to be eligible for insurance. He was immediately successfully referred to the residential substance use disorder treatment program, where he was admitted for care within 3 days of his arrival to the Doorway. Bob continues to make gains in his recovery. He has completed residential, partial hospital, and intensive outpatient levels of care. He has moved into long-term recovery housing as of last summer. The Drug Court is another successful program that would not be able to function without Medicaid expansion. In this program, clients commit to engaging in treatment for mental illness and addictions versus being incarcerated. Having access to insurance is critical to their success in the community. I was recently told the story of one client who had never entered treatment before Medicaid expansion. This person first became involved in the criminal justice system in 1985.
If you could start wrapping up, please.
Okay, they spent a lot of time in the prison system, but at 48 years old was finally able to get access to care, is working full-time, and went back to school. Without the Medicaid program, people like Bob and Joe would not have access to the services they need. This program is a lifeline for many individuals in need of treatment, and we ask you to please support with an ought to pass for Senate Bill 263. Thank you.
Thank you. Any questions? Representative Shapiro.
Thank you, Mr. Chairman, and thank you, Ms. Metzen, for taking my question. I know that even with Medicaid expansion, that the community mental health centers are struggle with funding and struggle with hiring people, struggle with paying competitive salaries. I think we all secretly are thinking, well, Medicaid expansion is going to be reauthorized. Some of the length of time, et cetera, is in question. But I think it's important for us to keep in mind that about 10 states have never passed Medicaid expansion. And so my question to you is, what would it mean to your center and the other mental health centers if Medicaid expansion went away?
Oh, thank you very much for that question. It's very important. I think it's important to know that we are able to serve a demographic that we were not previously able to serve. And I think that you would see an increase in the utilization of emergency departments, an unfortunate increase in overdose and other high-risk behaviors for folks who are not able to access treatment. The ability to access treatment with the ease that has been allowed with Medicaid expansion has served thousands of people who would not have sought care prior because they would have no means for payment. So it's of critical nature for our organization to be able to serve them and to be able to stay solvent in doing that because we do not have the capacity to provide the care without some type of compensation. Thank you.
Thank you.
Other questions? Seeing none, thank you.
Thank you very much.
Also signed up to speak is Richard Wiggins from Sanderton. Good afternoon.
Good afternoon, everybody. Thank you for this opportunity. My name's Richard Wiggins, and I'm a staff member at NAMI, New Hampshire. I grew up in Sanderton. I've lived there with my wife for the last 15 years. I have been in recovery from substance misuse and childhood trauma for the last 28 years. Having been able to grow in my recovery has enabled me to give back to many individuals as well as the community using my lived experience. I have worked in substance use disorder treatment, a sober living community based on the 12 steps, and now at NAMI, New Hampshire as a peer support specialist in a transitional housing service run by NFI North right here in Concord. My knowledge of the many benefits that Medicaid expansion of the Granted Advantage has brought to our state is a result of one of our two adult children's needs. He's 37 years old and has had a very difficult life starting in his early teens up to the present. His challenges began with skipping school, which led to marijuana use and eventual dropping out of high school early before graduation. Long story short, the substance use increased to the point of jail time, multiple treatment facilities, and bouts of homelessness. A little more than 3 years ago, he almost died from a drug overdose and was luckily found and brought to the hospital where he was on life support for 8 days. He is now living with a traumatic brain injury. It has been a long road to his own version of recovery, but he hasn't had a drink or an illegal drug for almost 3 years. It needs to be said that Jeremiah has struggled with mental health issues all along. Fortunately, he is living in Nashua and works at the Hearts Peer Support Center and has many folks around him that are so important to his recovery. Most of his success is due to the assistance from the New Hampshire Granite Advantage Healthcare Program. And I say most, that's a large part of it. SB 263, which reauthorizes the crucial and successful New Hampshire Granite Advantage Healthcare Program, is one of the most impactful measures the legislature can employ in supporting Granite Staters. And I must acknowledge my wife's contribution to our son's recovery, because she's a social worker and is able to go handle all the paperwork that is involved in getting somebody into this system. And I thank you.
Thank you. Any questions? Seeing none, thank you. Also signed up to speak is Christina Loader from Harbor Care.
Good afternoon.
Good afternoon.
My name is Christina Loader. I am the Director of Behavioral Health and Substance Use Services at Harbor Care, which is a nonprofit federally qualified healthcare center in Nashua, New Hampshire. I'm here today to discuss the importance of permanently reauthorizing the Granite Advantage Healthcare Program. As a healthcare center, we serve over 2,600 unique patients, many of which are on Medicaid. Instead of going over statistics today, I wanted to take a moment to share a client story that I think highlights the importance of the Granite.
Mr. Chair,
yes.
Would you speak a little closer to the mic, please?
Is that better? Okay, sorry.
Thank you,
Thanks.
Christina.
So I would like to take a brief moment to share a client story that highlights the importance of the Granite Advantage Healthcare Program. A client named Michelle, who came into treatment with us through our Cynthia Day Family Center, which is a residential substance use disorder treatment center for pregnant and parenting mothers. When she arrived, she was 6 months pregnant. She was using over 5 grams of fentanyl and crystal meth each day through IV, and she had been homeless for several months. She had no prenatal care up to that point. She was able to come into treatment and stabilize. She was able to access primary care through our health center, as well as dental, mental health, and substance use MAT services. She had her baby while she was living in treatment with us and was able to start her journey as a new mom, being healthy and happy. She received care for approximately 9 months and graduated successfully from our program. When she was graduating, she transitioned to her own apartment to live independently. She has maintained her sobriety for almost 2 years. She was able to access healthcare services she needed because she was insured through the Granite Advantage Healthcare Program. Now Michelle and her daughter are living happily and healthy together. Michelle said, "I am not surviving, I am living." Michelle's story is an example of how these benefits truly do help the people in our communities every day. So I'm asking that you consider permanently reauthorizing this bill. Thank you.
Thank you. Any questions? Seeing none? Okay, thank you. Also signed up to speak are Mike Rollo and Michelle Lawrence from the American Cancer Society. Oh, that's a fancy handout.
We aim to please.
Good afternoon, everyone.
Good afternoon.
My name is Michelle Lawrence, and I'm from Manchester, New Hampshire. Today, I'm here to discuss my support for SB 263. About 14 years ago, around my 31st birthday, I was diagnosed with a rare chronic cancer. Not a very fun birthday present. At the time, I was working as a case manager for a nonprofit organization and paying for private health insurance. My peers were planning weddings, purchasing their first homes, having their first kids, and I was left trying to wrap my mind around my cancer diagnosis. I needed to learn about my diagnosis and treatment options while figuring out how I would cover all the costs of treatment on my own. I didn't want to leave my surviving family with any medical debt or have to take on the burden of financially supporting me. I wanted to remain as independent as possible, as most adults do. And after research, I learned that cancer patients are 2.5 times more likely to file for bankruptcy after they are diagnosed, according to the Fred Hutchinson Cancer Research Center based in Seattle. They say life is priceless, but I beg to differ. It comes at a cost. As a single person supporting myself financially, the majority of my income went and has gone towards medical expenses. What I'm about to share is not a complaint, but facts, because I'm grateful for what I do have. I have done the math, and over the past 13 years, with co-pays, deductibles, and out-of-pocket expenses, I would have owned a very nice home by now, a nice car, and traveled. If I added up just the co-pays to see the doctors, it would be about $20,000. That's just to step in foot in the doctor's office. Over the past 13 years, I have delayed treatment, skipped doctor's appointments, not followed up with recommendations, and even delayed care due to insurance costs. At times, I had to decide whether to go to the doctor's office or pay rent. And I share this with you today because most people looking at me would never know that I was facing those choices. Those aren't decisions a cancer patient or anyone should have to make. I am not living the American dream. I rent an apartment, drive a 12-year-old car, and live paycheck to paycheck. Cancer is expensive and private insurance is just as expensive, but we say life is priceless and our actions need to start reflecting that. This year, when my employer let me go, I could not keep up with my health care costs, and I couldn't afford COBRA while trying to meet my basic needs. Applying for Medicaid was, and the best option. I was so thankful I qualified. With Medicaid, I've had the full access to all the medical care I need, including home health, therapy, medication, and for the first time in my cancer journey of almost 14 years, the primary focus has been on my health care, not my insurance and insurance costs. And with treatment and access to care, I have regained strength and even started a small part-time job. I'm not waking up in the middle of the night thinking about or having to decide to pay rent or delay treatment. I'm able to seek the care I need, follow up on recommendations, and not be concerned about racking up medical debt. I don't have to worry about debt collectors or those notices in the mail. The stress it alleviates is beyond words. It makes me emotional just thinking about it. It's why I volunteered to share my story with all of you today. Access to quality and affordable health care impacts us all on a micro and macro level. Not only am I a healthier person because I have the care I need and don't have to delay any treatment, I am able to contribute to society.
You could start wrapping up, please.
Yep. Medicaid expansion, or SB 263, would enable the state of New Hampshire to have healthier peers, constituents, and family members. It empowers people to access preventative care, follow doctors' recommendations, and take medications as prescribed. All of these actions have been proven to cause patients to utilize emergency services less, saving everybody from employers to you. Invest in Medicaid and show us life is priceless.
Thank you.
Mr. Chairman, just for the record, Mike Rollo, American Cancer Society, Government Relations Director. Inside your packet, I was going to go through, Michelle really was the focus today, not me. I was just here for moral support. But inside your packet, you'll see a letter from me, Michelle's testimony, one pager on facts and figures of what Medicaid expansion and cancer, what it means with cancer, for cancer patients in New Hampshire, and then a storybook about the impacts of Medicaid expansion and what it's had on a number of different cancer patients in our state. So with that, we're happy to answer any questions you may have.
Sure. Thank you very much.
Thank you.
Any questions? Representative King.
Thank you, Mr. Chairman, and I hope you'll indulge me. I'm just going to make a statement that I'm very thankful for your testimony today, and I know that you're under a great deal of stress. And I'm going to be thinking about you.
Thank you for your time.
Thank you, Representative King.
Yes, Representative McKay.
Thank you very much. I'd like to also make a statement for you and for everybody else that has testified today, telling very personal stories that keep reminding me as to why I keep coming back here for all of these years. It is the reassurance that I get from individuals who may be under pain when they're up testifying, but that it means a great deal to us to see so many people. And I can remember the day that we passed that vote. And I won't go into the details of what happened, but that was remarkable in and of itself. So thank you very much from all of us. I rarely say these kinds of things, but that it's been very touching today, and I think it has been for everybody else here.
Thank you.
Thank you, Representative.
And not to take up too much more time, but this program means a lot financially to a lot of businesses and to the healthcare system as a whole. But it's much more than that. And for organizations like mine, for people like Michelle, it means a lot more than the bottom line. It's their lives. So that's why we do the work we do. And thank you for recognizing that, Representative McKay.
Sure. Thank you. Any other questions or comments? Seeing none? Okay. Thank you.
Thank you.
Thank you very much.
Also signed up to speak is Jamie Powers from GH Recovery Solutions. Is Jamie Powers still here? I don't believe so. Okay. Oh, do you want to see if she's out there? Jamie Powers, yes. Thank you anyway. No, okay, thank you. Also signed up to speak is Dylan Knowles from, I'm not sure of the name of the company, but, okay. Dylan Knowles? Okay. Not sure of the name of your company, Home Something Living.
Home Something Living.
Okay. Okay.
Button on your microphone.
Yeah. Yeah, you need to put, there you go. Thank you.
There we go. First time.
No, that's fine. That's fine. Welcome.
Thank you.
You have about 3 minutes.
Okay, so I just go?
Yeah, whatever you got to say.
All right.
Yeah.
So as you already know, my name's Dylan. I run those two companies. A little bit about myself and why I have first experience as to the importance of Medicaid and related services is I grew up impoverished. I was born in Lynn, Mass, and then when we left there was no Mass Health. I got Medicaid in New Hampshire as a kid. Healthy Kids Gold, I think. And I was a great student, a student athlete, great GPA, and then I got addicted to prescription opiates. And from there, I kind of fell off a cliff. And only as a result of the services, which I couldn't have afforded on my own, am I alive today. Between having to go to, partial hospitalization or detox or being on life support when I overdosed. Not to be too graphic, but yeah, I only sit before you today because I was provided a service that I definitely couldn't have afforded myself. And now I have the not only honor but a responsibility to my peers who are going through the same thing locally, and they come out of detox rehab or they're homeless and they don't have the means to pay for their own services. And these individuals, over the first few months, they're allowed, they're able to get the mental health treatment they need, the physical treatment. Some of them come in with a lot of conditions. Drug and alcohol abuse are both devastating to the mind and to the body. And then after about a year, some of them make really good money and they pay really good taxes and they have their own insurance, whether it be, they pay themselves or through the companies they're at. And again, they're only alive and able to do this because of that initial stepping stone. So I know this isn't speculation. This isn't my guess. This is first-hand experience that this works. It works very well. And then ultimately, even if it's about money, at the end of the day, these individuals, myself included, pay really good money for taxes and continue to buy back into the program. Otherwise, we would be a burden on a system. We're not going to be turned down health care. Then we can't pay for it. No one's paying for it. And we create a problem rather than a solution. So that's my story, man.
Great. Thank you.
Thank you.
Any questions? Representative Weber.
Would you believe we all think you did a great job of testifying, and thank you for coming and sharing your
No
story.
notes or anything? Yeah, very good.
Thank you. It's hard to mess up your own story, right?
Hard to tell your own story. Courageously.
Thank you, ma'am.
Any other questions or comments? Seeing none. Thank you. Thanks for being here.
Thank you.
Also signed up to speak is Sean Canizaro from Hope to Freedom Recovery Homes. Oh, okay. All right. I'll go to someone else then. And I'm not sure the last name. Jonathan Gerson from New Hampshire Corrections into Action Service Living.
Yeah.
How close am I?
I'll let you know in just a second.
Sorry.
Thank you. Good afternoon, Chair and members of the committee. My name is Jonathan Gerson. I'm a resident of Manchester, New Hampshire. I'm a recovery advocate. I'm a board member of the New Hampshire Coalition Recovery Residences, and I'm the owner of 7 certified recovery homes. Our homes serve a total of 100 residents, serving both men and women. I come to you today representing those men and women. Typically, someone arrives at our recovery house after first completing some form of inpatient treatment first. Thankfully, with Medicaid expansion, New Hampshire has exponentially increased access to inpatient treatment options over the last 5 years, making it viable for providers to serve the Medicaid population. Once that individual completes their treatment program, they are then stable and appropriate for one of our recovery homes. When they arrive, many of them are connected to recovery support services such as LADAC and mental health counseling, medication management, and medicated assisted treatment. This allows for a continuity of care, which is incredibly critical in early recovery. These essential services would not be available to them without Medicaid expansion. Many of them wouldn't have found the doors to inpatient treatment to begin with. Now, fast forward several months into their stay with us, which ranges anywhere from 6 to 18 months. They're now gainfully employed. They are stable on medications. They are beginning reunification with their families and loved ones. They are resolving outstanding legal issues. They are becoming financially self-sustaining. They are now contributing to the community as opposed to burdening it. A large number of them are now offered health coverage through their employers. They no longer require Medicaid. With these examples, the Medicaid system is doing exactly what it's intended to do, to bridge the gap to a vulnerable population. Without Medicaid expansion, we have higher rates of homelessness, recidivism, overdose, and relapse. Medicaid expansion is a cornerstone of all the progress in New Hampshire's response to the substance use disorder epidemic. I speak for our residents when I say many wouldn't be here without it. I urge the committee and the legislature to permanently reauthorize Medicaid expansion. Thank you for your time.
Thank you. Could we get a copy of your testimony, please?
Thank you.
Mr. Canizaro, is he present? Okay. Welcome. Hope to Freedom Recovery Homes. Is that the name of your company?
Yes.
Okay. You have 3 minutes, sir.
Yeah. Thank you.
You can go ahead.
Okay. Hi, everyone. My name is Sean Canizaro. I am co-owner of Hope to Freedom Recovery Homes. And I might glance at my phone because I have a couple of bullet points that I want to touch on.
Sure.
And I'm not the most professional speaker. I just speak from the heart, and that's what really hits the people when I share my story, my experience.
Sure, that's
And,
fine.
You know, the thing is, I'm in recovery from heroin addiction, alcoholism, crime. Like, I have totally ruined my entire life. I have it back now. I got it back now. I've done almost 17 years in prison. I've been in and out of treatment centers in Massachusetts. And in Mass, I had to use state insurance. Up here, when I moved to New Hampshire, I'd suffered a near fatal overdose and ended up in a sober living, a recovery home in Littleton, New Hampshire. And when I went there, one of the requirements was I had to get a therapist, and I couldn't get it because I still had Massachusetts insurance. So New Hampshire wouldn't give me insurance until that was canceled. And I get it. And it just took a while. So, you know, thank God for Littleton Regional Hospital. They paid for me to see a therapist for over a year. And I was employed. I ended up getting a job up there, and then my employer offered me insurance, so I took that for a little bit. But what I was and I became the manager of that recovery house. And what I noticed was guys coming out of treatment centers that had to live in these sober living houses, that had to follow rules, but they couldn't because they couldn't get a therapist because they couldn't get insurance. Now, these guys don't have jobs. They're barely, cognitive. They don't know, some of them didn't even know how to make a bet, and the problem was I seen people leave because when an addict or an alcoholic feels like they can't do something, it puts a toll on the way we think and the way we feel about ourselves. So people were leaving and relapsing and dying because they couldn't follow the rules. And when someone gets clean, that's all we want to do. We just want to follow the rules and do the right thing. To speed it up, I would get phone calls to try to help people get into detox. And every time I would call these detox facilities, the first thing they would ask is, do they have insurance? And a lot of these guys that I was trying to help, they didn't have insurance. So what happens is now they continue to use. They continue to get high. And we all know what happens now. Now they continue to die. It's basically, if this doesn't get permanently reauthorized, like, people are gonna die. I had a good friend of mine on a waiting list. He was waiting to get insurance, and he relapsed and got high one last time, and he's dead. That was a really good friend of mine who struggled his entire life with drug addiction, alcoholism, and to speed it up a little bit more.
If you could start wrapping up, please.
Okay, yes. To speed it up a little bit more, I own a recovery house, sober living, like the one I got clean in, and part of the requirement is you have to get insurance and you have to get a therapist, because a therapist is very important for someone like myself to unpack all the trauma and stuff that we've been through. And we also allow folks that are on MAT, medicated assisted treatment, and I think every guy in my house that's on MAT, Medicaid is paying for. So if they don't have their Medicaid, they're gonna be dope sick, for a lack of better words. And what happens when we're dope sick, we go out, we commit crime, we rob banks, we rob stores, we steal from our loved ones, we get high, or we die. So it's either we get insurance or we can just buy body bags, because that's what's gonna happen. People are gonna die. So I urge you strongly, or encourage you to strongly reauthorize this permanently, and thank you for your time. I appreciate it.
Okay, thank you.
You're welcome.
Also signed up to speak is Alyssa Nye from Merrimack County Drug Court.
Good afternoon, Honorable Chair and members of the committee. My name is Alyssa Ng, and I am the coordinator for Merrimack County Drug Court. I'm in support of continuing Medicaid expansion in SB 263. I'm employed by Riverbend, Merrimack County's community mental health provider, so I also have a front row seat to the benefits of Medicaid expansion. Insurance is another huge deterrent and roadblock for our participants.
Can I interrupt? Could
Yeah.
you move the microphone closer to you, please? We're having a
Sure.
little trouble hearing.
Better? Okay. Insurance is another huge deterrent and roadblock for our participants who struggle with substance use disorder. Medicaid expansion has allowed them to receive medicated assisted treatment, MAT, higher levels of substance use treatment like residential and partial hospitalization programs, psychotropic medications, and the ability to focus on their recovery and reintegration into the community instead of astronomical medical bills. The vast majority of our participants rely on Medicaid expansion for the substance use treatment and overall health care. The stability that Medicaid expansion has provided allows individuals to address their substance use disorder, which allows them to find employment that provides proper benefits along with the paycheck they need to become independent. I wanted to share with you a few specific stories I have seen throughout my time with Drug Court in Riverbend. One participant who has spent years in active addiction causing permanent issues with his teeth has been able to have 10 teeth pulled while on AmeriHealth and has fully fitted with posts and partial dentures. His mental health and self-confidence has entirely changed since his procedure. Until this month, AmeriHealth was the only Medicaid plan to offer dental coverage. I've also seen many participants go from relying on Suboxone, a daily medication, to fight cravings and physical withdrawals, to Sublocade, a monthly injection that provides the same effects. Sublocade is $1,000 an injection, but it has decreased medication misuse and allows for a slow taper off medication altogether. Lastly, a client with persistent mental illness who is living in a rented storage unit was able to stabilize on the correct medications, move into an apartment, find full-time employment, and graduate our program. Medicaid expansion hasn't just helped individuals like these. It has played an essential role in building New Hampshire's overall substance use treatment system. When I started working for Drug Court, obtaining a residential treatment bed for a participant who was actively using substances was upwards of 3 weeks. Since Medicaid expansion, residential facilities have opened their doors or expanded services as they are able to remain open due to program fees being paid by state insurance companies. It now can take less than 24 hours for acceptance, saving time and drug court resources. The drug court team is housed within the Choices program of Riverbend. We share a space with their treatment program. Choices is a voluntary substance use program. The number of intakes and services rendered have increased substantially since Medicaid expansion. Without insurance as a barrier, people are voluntarily seeking treatment and changing their lives and their families' lives. People voluntarily seeking treatment and building their recovery skills are not making it to my office door with multiple felonies following them. Decreasing correctional facilities spending, drug court grant spending, court and policing expenses. The drug crisis in New Hampshire may never be fully eradicated, but we can continue to do everything we can to combat it and reduce the amount of overdose deaths this state sees every year. 463 overdose deaths in New Hampshire last year. It's terrifying to think what these numbers would look like and how many lives would be lost without Medicaid expansion. They are to support individuals and families in need and support our overall treatment system. I want to thank you all for your time and your consideration in permanently reauthorizing Medicaid expansion.
Thank you. You taking questions or?
Sure.
Representative Weber has a question.
Thank you so much for taking my question. I hadn't thought about this aspect of it before, but would you say from your experience that this not only has benefits to the individual, benefits to healthcare overall, but is also a crime reduction measure?
Absolutely. Providing treatment and having that available for our participants, we see less recidivism. We do like a risk assessment, which is the risk to reoffend. To be in drug court, you have to be high risk on that assessment. When I've been redoing them before my participants graduate, they go from high risk to low. It's there in the numbers with the treatment that we're able to provide.
Thank you very much, and thank you for the work you do.
Thank you.
Other questions? Seeing no other questions, thank you. Also signed up to speak is Keith Howard from Hope for New Hampshire Recovery. Mr. Howard here? Is he out in the hall perhaps, or? Okay, thank you. Also signed up to speak is David Jarrett from BIA.
Thank you, Mr. Chair, members of the committee. For the record, my name is Dave Juve. I'm a Senior Vice President for Public Policy for the Business and Industry Association. I'm here to convey the strong support for New Hampshire's private sector employer community for this bill. It's been a long hearing, a fruitful hearing, so I'll keep my testimony short. I have provided written testimony. When you receive the written testimony, you'll notice at the bottom BIA's mission, which is promoting a healthy climate for job creation and a strong New Hampshire economy. It's hard for me to think of any other bill this session, aside from perhaps the state budget, that has more of an impact on job growth and a healthy New Hampshire economy. But it could easily go the other way if this program is not renewed at the end of the year. We've heard a lot from the provider community and a lot from individuals explaining how important expanded Medicaid is to them. It is equally important to New Hampshire's employer community. If this program goes away, that means at the very least, $1 billion every biennium will not be coming into the state from the federal government. Obviously, that will have an economic impact. Hospitals will feel it directly, but hospitals sound like a cold entity. Hospitals are really made up of individuals, employees, whose job is to provide care to all of us. All of those individuals will feel the impact of that loss of federal aid to support this program, which means that their spending will be impacted. Their spending for food, their spending for rent, their spending for mortgage, their spending for schools, cars, any commodity
will be impacted. The ripple effect of losing that money will spread throughout New Hampshire's economy. But I'd also like to focus on why this is important for employers, especially employers who provide a health care benefit, and even more especially for the small business employers who struggle to provide a health care benefit. If we lose that revenue from the federal government, which supports this program, we'll go back to the bad old days of 10 years or more, where hospitals had to pass on the costs for uncompensated care to other buyers of health insurance, which in New Hampshire is primarily employers. What that means is employers, especially the small business community, it will make it even more difficult for them to provide a health care benefit. So I would suggest, if this program is allowed to sunset, it's not only the people on the program who will lose access to health care insurance and health care services, it's many employers, especially of the small business community, that will also lose their health care benefit.
Wrapping up, please.
Happy to answer any questions.
Thank you. Representative Shapiro.
Thank you, Mr. Chairman, and thank you, Mr. Gervais, for taking this question. I wonder, since you're talking about the effects on medical care, obviously, and on individuals, but also on businesses, on employers, on the economy, and all the cascading effects on the other parts of the economy, can you speak a little bit about what the advantages or disadvantages would be of reauthorizing the program for 2 years versus making it permanent?
Well, we support permanent reauthorization. I want to make that clear. One of the issues about just providing a 2-year reauthorization, I mean, is a practical reason. There's no reason to do so. This is not a new program. We have 10 years experience and 10 years of documented data showing how effective it is. So it doesn't make any sense to only reauthorize it for 2 years and then have to come back 2 years later and reauthorize it again. Other people testifying have spoken to the safeguards that are in the program. So as a practical level, I don't believe that that's necessary or helpful. It also, I believe, would impact in a negative way competition in the state. Right now, for those entities that provide Medicare coverage, it would be helpful for them to know that there is a permanency to this program. By just having a 2-year guarantee, you are acting as a disincentive for other MCOs to enter this market. So I would argue, if you really want to increase competition and have a positive impact on healthcare costs, this should be a permanent reauthorization. Take that question away.
Other questions? Any other questions? Okay, thank you.
Thank you, Mr. Chair.
Also signed up to speak is Dr. John Hink from the New Hampshire Psychiatric Society. Doctor, you've indicated 5 minutes. I'd appreciate it if you could keep it to 3.
Yes, I think it'll be less. Good afternoon. My name is Dr. Jack Hink, and I'm the president of the New Hampshire Psychiatric Society. The New Hampshire Psychiatric Society strongly supports SB 263 because we believe it will improve access to mental health care and substance use disorder treatment in our state. Better access to mental health care and substance use disorder treatment is really the best way to address the mental health crisis in our state, as well as the opioid epidemic. Suicide is the 9th leading cause of death in New Hampshire, according to the most recent statistics from the Center for Disease Control. And better treatment of underlying psychiatric disorders can reduce the risk of suicide. As you know, there is a mental health crisis in our state where citizens often must wait days or weeks in the emergency department to access mental health care that they need. It is much better care and more cost effective to enable citizens to get outpatient care covered by Medicaid at an earlier stage in their illness where they can be more successfully treated and avoid the need to be admitted to an emergency department or hospital. SB 263 may also help to address the opioid epidemic in our state by helping citizens to get treatment for opioid use disorder more easily, which can help prevent tragic deaths from overdose. In closing, the New Hampshire Psychiatric Society strongly supports SB 263 as a great way to improve access to mental health care and substance use disorder treatment to better address the mental health crisis and opioid epidemic in our state. Please support SB 263. Thank you.
Thank you. Representative Weber?
Thank you. Do you know the number of practicing psychiatrists in New Hampshire at this point?
I would say 500.
Okay, thank you.
Other questions? Seeing none, thank you.
Thank you.
Also signed up to speak is Dr. Andrew Laurer from the American Cancer Society and also representing himself. Good afternoon.
Good afternoon, Mr. Chair and committee members. Thank you for the opportunity to testify today. My name is Andrew Lair. I'm a citizen. I'm a resident of Lyme, New Hampshire. I'm a general surgeon, a surgical oncologist, and a health services researcher at Dartmouth. I've had an opportunity over the last 15 years to work in states that have not expanded Medicaid, states that have expanded Medicaid. Additionally, over the past 10 years, I've studied Medicaid expansion and its impact, particularly on common and costly surgical conditions and cancer care. It's in this capacity that I think I can provide my strong support for SB 263 and urge you to do the same. I moved to New Hampshire about 5 years ago and found the independent, strong and resilient nature of Granite Staters both to be inspiring and frustrating at times when I'm trying to get them to follow post-operative orders. But even with this resiliency and the strong communities that define New Hampshire, the complexity and cost of healthcare in the United States are too much. I've seen what happens in prior states when we don't have Medicaid expansion. Roy, a 64-year-old gentleman who wasted away, lost 30 pounds, increasing abdominal pain, waiting to get Medicare before his family found him down in the bathroom in septic shock with a tumor that had eroded through his colon. Tanya, a 52-year-old woman, mother of two, working mother of two, who I first saw to put a permanent catheter in to get chemotherapy 7 months after her diagnosis. She couldn't afford her insurance, and subsequently she had to spend her time finding a job while feeling the cancer grow in her breast. I think about another gentleman we performed a life-saving liver surgery on, and on the day of discharge, I went in to talk to him, and he was crying. And I said, everything had gone great from surgery. He said, I'm grateful for all that you've done, but my family had to sell the farm that's been in our family for 4 generations in order to pay for this. Now, these aren't only anecdotes. Both in Massachusetts and in states across the country, we know that expansion is associated with patients presenting with earlier disease. That includes earlier stage cancer that's more treatable and results in longer survival with those. My preliminary evaluation in New Hampshire, as a matter of fact, which I'd be happy to follow up with you all, shows that after New Hampshire's Medicaid expansion, similarly, there's reductions in the stage at which cancer was diagnosed in New Hampshire. This corresponds to additional likelihood of getting treatment and improved survival. Beyond the patients that it impacts, I also want to recognize the stability and well-being that Medicaid expansion has on our surgical workforce. We've talked a little bit about the role that Medicaid expansion plays in hospital stabilities. Prior research shows that there's a significant increase, particularly in rural hospital closures in states that have not expanded Medicaid. And so this isn't a hypothetical factor. We know from across the state that without this Medicaid coverage and with the pressures that are going on in healthcare right now, rural hospitals in particular are facing that stress. Finally, I want to talk about the moral injury that has led to a significant workforce shortage.
Yeah, if you could start wrapping up.
I'd be happy to. Not only from taking care of patients that lack insurance, but being told that we can't, kicking out patients before we can take care of them because they don't have insurance. That puts a significant moral injury on individuals that leads them to quit the job or seek care elsewhere. This isn't abstract. We're recruiting a surgeon up to Dartmouth right now who, when I told her about this hearing, said, well, maybe I'll wait to hear what happens. This is a very tangible thing for the lives and livelihood of Granite Staters, as well as the well-being of our surgical and healthcare workforce. I urge you to support 263.
Okay, thank you. Any questions? Yes, Representative Murphy.
Great. Thank you very much, and thank you for taking my question. I'm just following up one of your comments. Have you, and maybe I misinterpreted what you said, but have you ever been told that you should not or could not take care of a patient because of their insurance coverage?
Yes, not in New Hampshire.
Oh, okay, that's
not in New Hampshire. In New Hampshire, I have not for Granite Health, not for any of the marketplace plans, and not for the few uninsured that do happen to come in.
I just want to be clear, but during your time at DH, you have not been told that you could not take care of a patient because of insurance coverage?
That is correct.
Thank you.
All of those examples were in prior states or prior to Medicaid expansion.
Thank you. Other questions? Okay,
Thank
seeing
you.
none. Thank you. Also signed up to speak is Keith Tuning from Waypoint. I'm not sure how well I did with your last name. I apologize if I didn't do it well. So,
Close enough, Mr. Chair. Hi. Mr. Chair, members of the committee, my name is Keith Kinning. I'm the Advocacy Director at Waypoint. We sit here in strong support of SB 263. Want to give a little bit different perspective on this. The way we approach families these days is we've learned not to approach it as a child issue or a parent issue. We approach things as the whole. The family needs help as a whole. We've done this now through voluntary services in a lot of different ways. And we see SB 263 as a part of that. So if you think about it this way, a healthy parent is a providing parent, and a healthy parent is a caring caregiver also. If they're healthy, they can do the things they need to do. And we also know that Medicaid expansion is critical more than just adults, but is crucial to the health and well-being of the children. So it's not just the parents that benefit, the children benefit. How do they benefit? In New Hampshire, more children gain coverage in the first 5 years following the adoption of Medicaid expansion. This is consistent with research done in other Medicaid expansion states showing that when parents gain coverage, they are more likely to enroll their children in coverage and to take their children to the doctor. This has in turn demonstrated an increase in well child visits for children in Medicaid expansion states. So when the parent gets the health care, they're more likely to take care of their child in the healthcare system. So they're able to go off and provide. And when the child gets otitis media, they're able to put their child into the medical system and make sure that that child immediately gets care. And they don't hold the parent back from going off to the job that they need to go off to in order to provide for the family. So we see SB 63 and Medicaid reauthorization as beneficial to the entire family. We think it keeps the families together and keeps them out of homelessness and other situations that they can find themselves in if they don't have the health care and they can't get to their work. So for this reason that we support SB 263, Representative Shapiro was kind enough to grab some of my testimony. I handed it around early, and you should have it. It looks like this. It has all the footnotes about our basic research on this issue, and I'm happy to take any questions.
thank you. Any questions? Seeing no questions. Thank you very much. I have no one else signed up to speak on Senate Bill 263. Does anyone else wish to speak on Senate Bill 263? Seeing no one, I am going to close the public hearing on Senate Bill 263. That is all of that's all of the legislation we had scheduled for hearings today. So we're going to stand adjourned until next Wednesday, at which time we will have additional hearings. Stand adjourned. Thank you all.
Oh,
The only thing I've ever learned from taking my children to nutrition 8,000 times. So they have tried this meeting. They will try
All night.
Good. I don't think we did.
Yes. Right.
I'm sure.
Oh, yeah. Yes.
No.
How
you doing? Good. Good? Yeah. Where's mine? Oh, I know exactly. Yeah.